discussing benign breast disease. You will find a lot of differences when it comes to management of diagnosis and management of benign breast disease. When it comes to malignancies, the guidelines and the management is quite clear. Generally, we have a clear consensus on the management. But when it comes to benign, the management you will find there will be huge variations. Now, there will be 3 surgical people, 1 radiologist and a pathologist. Among 3 surgeons, you will find a lot of differences in management because the guidelines are sometimes not very clear. So we have our own ways and different ways of managing these conditions. As long as they are reasonable, rational, that should be okay. So we will find different views on the same problem, differences in the management among us. Of course, from exam point of view, these are important topics. More importantly, for management, you will find benign breast diseases are far more common than malignant disease. And although it may not cause significant physical morbidity, they cause a huge psychological morbidity for patients who are having these conditions. I'm sure you would have experienced that. So it's about, now the objective of our discussion today is going to be rational assessment of these conditions, importantly excluding malignancies where it is relevant, and planning and intervening where it is necessary. We will discuss what are the interventions available, when to intervene, and what different options are available. There will not be single intervention in most situations. There will be varying views. So we'll have a discussion, plus we will be asking a lot of questions from you. There are a lot of people, experienced people who are going to be sitting for the exam. So we will have a discussion on the topic. You are also free to ask questions at any point. This is not a lecture. There are slides, but we will try to have a discussion and answer your questions. So Kanchana is the person who's organizing all this. She has taken all the hard work in doing all the background work. So I'll hand this over to Kanchana to start the discussion now.
Thank you, Prof. Sanjeeva. Good morning to you all. On behalf of the College of Surgeons, let me thank all of you for attending this session. It doesn't look as exciting as malignant breast disease, but you will realize when you're actually practicing as surgeons, the most challenging cases to manage are benign breast diseases. As Prof. Sanjeeva said, the management sometimes is quite vague. So first, let me introduce our panelists. So to my right-hand side, we have Dr. Sandeepani Jayasurya, consultant radiologist from the Apeksha Hospital. She's a very experienced radiologist when it comes to breast disease. And next I have Dr. Karisma Fernando. She's a consultant histopathologist from the Department of Pathology, University of Sri Jayawardenepura. Thank you both of you for attending today. And then you all know Sanjeeva, sir, Prof. Sanjeeva, and Dr. Nalinda, the general and breast surgeon from Ragama Hospital, will also attend in a few minutes. Until he comes, shall we start? Yeah. Can we have the presentation? So what we thought was to make it more interactive, to have like a case-based discussion, which you all are used to. I will moderate the session. You can always ask questions in between. We'll try to take it case by case and see. Right. So just to get an idea, by raise of hand, how many are there from the exam batch? All right, and the others are second years and first years, is it? Right? Okay. So we'll move to the first scenario. So sort of the outline of today's discussion based on, so I've categorized breast diseases into 3 groups. Fibroepithelial lesions, then we'll discuss inflammatory breast diseases, and next we'll go into proliferative lesions with atypia. So to start off with, let's discuss some cases under fibroepithelial lesions. And this is the first case. You can just read up. It's about a 20-year-old female. I'm going to have a neck pain if I start twisting into that, so I'll just read from my computer. So a 20-year-old female presents with a mobile lump in the right breast for 6 months. And on examination, there's a 2x3 well-defined firm mobile lump in the right breast, upper outer quadrant. If we could just hand over the mic to... You're going to start.
Since this is a 20-year-old female with a well-defined lump, next I would like to go ahead with ultrasound scan of the breast. Because most probably, considering the age, this likely to be a fibroadenoma. And in that case, because it's less than 25 and the size also 2x3, the ultrasound will be enough for the further management. Yes.
Let's...
What is the classic appearance of a fibroadenoma?
It's a well-defined
typical, well-defined, what we call a parallel oriented along the lines of the breast lesion, solid lesion, relative hypoechoic, parallel well-defined. So all those features are there. We call it a probably benign. We cannot say it's a fibroadenoma. But in the clinical context, if your clinical diagnosis is a fibroadenoma, in this context, ultrasound is good enough for us to confirm. Ultrasound, other uses of ultrasound are until you can assess the size, which will be helpful with your malware. Second thing, if there are any other lesions, those also will be seen, which will help with the malware and management. If the ultrasound is a typical fibroadenoma, that's probably benign in this situation. Look at the equator, the chance of it being malignant, like what we said, below the age of 25 years is almost zero. So it is not mandatory, or it is not required that we do a pathological assessment, not essential. But you may do it, you have to take it out, and you have a, yes, we go on, we will discuss the rest. Any questions on that? Yes.
Yes.
Then they are go. That's the fibroadenoma. Where the patient was white. Is all on saying matching of the pathology for a breast cancer. And complexity cannot catch it.
So just we'll move on to complex a little while. So yeah. So I will, so you want to go ahead with an ultrasound breast to see whether it is a fibroadenoma. Let's ask the radiologist just to give us an input on that.
Yes, this is the image of fibroadenoma. As Dr. Sanjeev told, it is parallelly oriented. Width is more than height, and it is well circumscribed. There could be macrolobulation, and there could be mild posterior enhancement. The minimal internal vascularity could be there, and the overline and surrounding parenchyma is normal. That is the typical appearance of a fibroadenoma. There could be complex that fibroadenomas. We will move to that part later. And the mammography appearance. Minimize
Or that to see that photograph and understand, because sometimes all of us have come across situations with a young girl coming with a mobile lamp. Ultrasound may not have this appearance. The radiologist might say it is a fibroadenoma. Even I have had that problem. You will think that it was not that. So if we just avoid biopsy, we can potentially use a malignant patient. Just because the patient is young, just because the lesion is mobile, doesn't mean that it is always. I have had a couple of patients. When I go back, I realize actually they are not looking at the images. They are not very oriented. They are not well defined. But the report has come as Paget street or probably benign. So going by your criteria, no need to do it. So now I have learned the lesson. Always we look at the images. If the images are not available, we get a repeat ultrasound scan. That is a good practice. But we don't want to miss. Most of the regulars are good. But occasionally we get wrong report. So it's always everybody is not good. So I'm in the sense, those what asked as well. People who do general radiology may not be accurate. Sometimes we get regular reports. The worst I have seen from this Paget 3 to 5. Is it 3, 4, or a 5? We don't know. It says conclusion, deletion, Paget 3 to 5. So when it comes and we make a decision, most of the time, no. We want a better report. So in that case, you can create the images yourself. No? Otherwise, you don't get a repeat ultrasound scan. So we are going to decide our further management based on ultrasound in that situation.
Just I'll alter the case scenario slightly. Imagine if this patient was 40 years old and your clinical diagnosis is still a fibroadenoma. Would your investigations change? Will you? What are the investigations you would like to do?
In that case, I would do an ultrasound scan plus a mammogram as well. And then anyway, I will go ahead with the core biopsy.
Yes, we just will get an input from the radiologist before we move on. So this is an image of a mammogram with a fibroid.
If patient's background is highly suspicious, patient age is more than 40, or more 35, we can do mammogram with the compression and magnification view. This is the mammographic images, the lobulated, the mass, dense mass with the lobulated margins. In the first image, there are no internal calcification, but in the second image, we can see macrocalcification, popcorn calcification within the lesion, but sometimes it's not same as all the time. There could be simple calcifications. In that case, we have a doubt of pleomorphism, but if there is a doubt, we can go ahead with biopsy.
Right.
Question.
Yes.
If a lesion comes as Paget 3, for example, in that patient, should we do a biopsy? So same lesion, but in a 40-year-old woman, not a 20-year-old anymore. Should we do a biopsy or not? What do you think? The ultrasound and the mammogram report is probably benign. That is Paget 3. Should we do a biopsy?
We can discuss with the patient regarding the options.
What do you mean options?
One is ultrasonic and mammographic surveillance of the lesion. The other option would be to do a core biopsy in the lesion.
So let's say there is a 3 centimeter lesion, same patient. Would you discuss follow-up or biopsy or nothing? Yes.
In that case, considering the age and the Paget 3 lesion, I would go for a core biopsy, sir.
Why?
So age, she's an elderly patient, I mean,
Not
40.
Don't say elderly.
40,
40.
40 and Paget 3 lesion, there is a chance of malignancy of around 5%. So it's better to go ahead with the core biopsy.
Okay, so number is a little wrong. What the guideline says, Paget 3, average risk is about 2%. But there are other factors that we need to consider. For example, below 25, we discussed the risk is nearly 0 if it is Paget 3. Similarly, if the lesion had been there for, let's say, 10 years, she has previous records to prove that it has not evolved over time. Then again, the risk becomes next to 0. But if the patient is, let's say, for 40, 50, 60 years coming with a recent onset lump, even if it is Paget 3, I would be very worried to follow up. Just follow up. I would definitely, especially if the lesion is big, unless it's a few millimeters in size, I would definitely do a biopsy because we don't want to miss potential malignancy in that situation.
Absolutely correct. So other thing is, then the family history, assess the risk assessments. Sometimes these patients may have previous biopsies. So theoretically, what they say is a previous biopsy is a risk factor, but I don't know how to do it. But I have also come patients who had a biopsy to say it's a P2 fibroadenoma and later 3 years down the line growing into a malignancy. So don't take a risk. If there's a 40-year-old coming with a new onset lump, better to go with biopsies, even though the clinically, radiologically, or is benign, better do a biopsy and confirm.
What type of a biopsy would you consider in that situation?
It's a ultrasound guided core needle biopsy.
Why not FNAC?
FNAC, it's only give us cellular features, so we can't assess the histological characteristics.
Okay. Are there any situations when it comes to breast disease where you would consider a fine needle aspiration?
In a histological proven malignancy, if there are any other lesions in the same breast, that we need to confirm whether it is malignant or benign, and also in if there is a axillary lymph node, we can go for a FNAC.
Okay. First one, I probably wouldn't agree completely. We'll ask the radiologist.
So just can I ask a question from the panelists then, just to make it clear to them? So in a 20-year-old, would you complete the triple assessment on this patient as opposed to the 40-year-old? Nalinda? So in a 20-year-old, would you complete the triple assessment if the ultrasound scans came as fibroadenoma with a cytological diagnosis?
If it is clinically benign, and if the radiologist says it's a virus 2-3 lesions, so I would offer surveillance, only follow-up. No need for go for excision.
So for FNAC?
Yeah.
Confirm that it's a fibroadenoma. To offer surveillance, should we go for a cytology?
Solid lesions, we don't do FNAC. If you want to do assess with a histological diagnosis, tissue diagnosis, better to go for a core biopsy.
Charisma, would you like to just discuss about the cytology and biopsy? What is?
Yeah. So in this patient, if it's a young female, it's a mobile lump, and radiologist confirm that it is a fibroadenoma, then pathology-wise, cytology, FNAC will suffice. Will suffice. So what you see on cytology. So what you see on cytology is basically a very cellular, cohesive sheets and clusters of cells, which has got like the staghorn appearance. And as you go on to the higher power, you'll see that these epithelial cells are mixed with myepithelial cells, and you see this abundant bare oval nuclei, which are basically myepithelial cells with their cytoplasm stripped. And then the other feature that we see is the presence of a stromal fragment. So when you have a culmination of all these features, it is diagnostic of a fibroadenoma. You do not need to go for a biopsy. Problem arises, sometimes we don't get the cellularity, we don't get these stromal fragments, we don't get these bare oval nuclei, or sometimes we have these small clusters where you don't see admixed myepithelial cells, or as Prof. Sanjeeva said, in older patients and all, that in that case, we will ask for a biopsy instead of a cytology. So in the biopsy, it becomes quite obvious. So basically, we all know that fibroadenoma is a biphasic tumor. So it basically has both epithelial and stromal component. So you see the pattern as intracanalicular and pericanalicular. Of course, it doesn't have much of a prognostic significance. So nowadays, most of the pathologists don't even report the type. And this pattern comes about with how the shape of the epithelial component is. So if you have a compressed glandular structures and all, we call it intracanalicular. If he has got glands with patent lumen and all, we call it pericanalicular, and the stromal fragment usually is paucicellular, it's myxoid, sometimes it could be fibrous. And when you look at the glandular component, why do we call it benign? Because it will always have the superficial epithelial and it will have the basal myepithelial layers.
Okay, I told you at the beginning, there will be controversies. We may have differences in management. Personally, I don't like FNACs of any solid lesion, unless it is very small, where a biopsy is technically, a co-biopsy is technically difficult. A lesion that a few millimeters in size, we may consider a FNAC as adequate, but any other situation, either we do not do anything and follow the patient up closely, or what we call short interval follow-up, or else I prefer personally to have a co-biopsy if I'm going to make my decision based on co-biopsy. Because FNEC, as you know, as she mentioned, sometimes the amount of cells that they get is not enough for them to conclusively say what the lesion is. So we say sensitivity 80% or whatever. So I feel in most situations that is not good enough information for me personally to make the decision in relation to the management. That is my personal opinion. I would like to hear from Nalinda also.
All over, not the both of us, all over the other parts in the world as well, the place for FNAs in solid lesion has gone down, right? It's always co-biopsy. The only instance that they consider doing an FNAC, if you find a nodule area, which is P3, P4, you cannot see a targeted lesion on ultrasound scan or mammogram, then you will do some FNAC from that area just to see what there is. Otherwise, there's no place for FNAC in lesions of the breast. But as someone said, the only thing is for the axilla, if you see a lymph node. Not that you can't do, I don't know, they are reluctant to do co-biopsies, but FNAC is good enough for the lymph nodes.
Yeah. Again,
Yeah,
just 1 second.
yes.
So in that situation, because we have confirmed the malignancy in the breast with a co-biopsy, for a small node, sometimes co-biopsy technically is difficult. That is the reason why they do a FNAC, just to confirm. But if the patient comes with an enlarged node with an indeterminate lesion in the breast or no lesion in the breast, always do a co-biopsy from the lymph node, because we want to know the exact pathology, the receptors, etc. That will help with future management. So in that situation, FNAC is not adequate. But in a patient with a or a BIRATS 5 lesion with an enlarged node, in that situation, FNAC is adequate. But otherwise, co-biopsy. Co-biopsy should be the ideal, because as surgeons, if you are making a decision based on the diagnosis, pathological diagnosis, I prefer to have a more solid diagnosis than a simple FNAC.
Thank you. So we'll move on to our case again. We'll come back to that. Again, to recall, so this patient had a 2 by 3 centimeter lesion. Clinical diagnosis is fibroadenoma. To make it easier, let's say an FNAC is done and that also shows it's a fibroadenoma. Who's the next? Yeah. So what is your plan? The patient is concerned. The patient wants the correct management.
So it will also depend. So it will depend on history with, again, like sir mentioned, if there is a.
Sorry, I can't hear.
If there's a background history of breast CA, past history.
Let's assume there are no risk factors.
And then you also need to confirm with her what exact concern is, whether it's anxiety or whether someone has told it could be a malignancy. So you just need to clarify that. And then, since it is clinically and radiologically as well as. It's not working now. Might be what I. So you mentioned.
Andrew, you all can come to the front seat.
So the patient does not have a family history of breast CA or a past history of similar fibroadenoma excision with ATPia. You need to discuss with the patient about what her concerns actually are, or whether it's just anxiety or whether it's someone has told her that there could be a risk of malignancy, etc., and find out exactly the reason for her current presentation. And then, since it is clinically and radiologically as well as cytologically confirmed to be a fibroadenoma, she can be reassured that this is indeed a benign condition, and thereafter discuss with her what she really wants. If she's still anxious about it, then
right. So let's say you have alleviated her anxiety. What is your surveillance policy? And what are the clear indications, very clear indications to go ahead with surgery in a fibroadenoma? And Sanjeev, Professor Sanjeev and Nalin, they can add into questions if you all want.
You can go for a short interval follow-up. The clinical examination on ultrasound may be 6 monthly, especially for a lesion like this, which is 2 by 3 centimeters. However, if the lesion is, say, more than 4 to 5 centimeters, or what you call a large or a giant fibroadenoma, then sometimes differentiation between fibroadenoma and phyllodes may be difficult on cytology. In that case, you may have to go with excision biopsy or an excision of the lesion with or without a margin accordingly.
What do you think? When you go through I don't think there are clear guidelines. There are many guidelines, but when you look at the Association of Breast, the UK guidelines or USA guidelines, one cutoff they give is age. If the patient's age is above 40, to go ahead with a diagnostic excision. Do you all agree with me, or?
Yes, so it's very varied. There are no clear protocols or guidelines. So it's a very individual-based practice. As you mentioned, the UK says if there's more than 40, they will offer surgery. Less than 40, they will not offer surgery.
Right.
Sometimes they will not even offer follow-up.
Yes.
So in our country, we do offer follow-up once in 6 months or once a year at least. But the fibroadenoma problem is if it is increasing in size during the follow-up, naturally the patients will be worried and you won't be able to convince them anymore, right? So otherwise you will have to do repeated FNACs or cow biopsies to tell them. Rather than doing that, it's much easier to get the lump out, right?
Yes.
So other thing is, if the younger patients, if they become pregnant, with the hormonal surge, these will increase in size enormously. So if that happens, you will have to take them down. Otherwise, sometimes the periareolar fibroadenoma tend to interfere with the breastfeeding as well. The duct will be, the nipple will be pushed away, the baby can't suck, so a lot of problems. For a benign lesion, nobody has to suffer like that. So then in that instance, we will offer surgical excision. But if you are doing it, better to do it before the lactation starts, because there's a small risk of fistula formation. If you do it during the lactation period, it's about less than 1%, but theoretically it's there. So that's the policy for all the patients. If you can't convince them for an active follow-up who are having no added risk factors, then we will offer surgery. Otherwise, we will offer surveillance once in 6 months and once in 3 years, the routine screening mammogram.
Yeah.
Nalinda, do you have a size cutoff for removal of fibroadenoma?
Yeah, usually, if you see the literature, it says after more than 2.5 to 3 centimeters, it rarely goes down, right? Otherwise, there's a 40 to 60% chance it will regress with time in the next 6 months to 1 year. But in our setup, I believe the size is around 2 to 2.5. We don't have enough data to go against the Western because the numbers are small. So I keep it around 2.5 centimeters. If it is less than that, surely we can offer, if you can convince the patient, surveillance, active follow-up.
Yeah, so again, it varies. I have a slightly higher threshold. I go up to about 4 to 5 centimeters. Up until that, especially if the patient is young, unmarried, I want to do avoid is a scar, unnecessary scar. I would follow the patient up for a couple of years. If it is getting bigger, definitely I would go ahead and remove it. But if it is staying the same or if it is regressing over time, even as half a centimeter during the following years follow-up, then I know it's a lump that is regressing. Because anyway, we are not in a hurry. Reassure the patient. If the patient can be adequately reassured, then I would follow the patient up in maybe 1 year's time with another ultrasound scan. I'm talking about young girl. Then if size is going down, I would just follow the patient up. If it is getting bigger, would offer surgery. But the 40-year-old, it's a total different story, because as the age increases, we know that the risk of malignancy also goes up. And also the other issue that might come up is you reassure the patient and send the patient home. So this is a benign lump. Even the next lump, patient might think, okay, I've got a similar lump. Why should I go to the doctor? So we have seen patients like that where they ignore a malignancy, unlike in a 20-year-old. And this is not 39 and 41. As the age increases, gradually we know the risk of the lesion being malignant gradually increases. So we would have a lower threshold to remove lumps in older people, especially if they're over the age of 40 years. But below the age of 40 years, I probably would have a much higher threshold to remove these.
I have come across girls having more than 10 to 15 fibroadenomas in one breast and bilateral. In that case, what we have done follow-up ultrasound. I have come across that it was removed if it is getting enlarged. What about the place of ablation for microadenomas?
Sandipani, we are going to get into that. And I thought I'll be asking you that question, Sandipani, actually. Yes.
When you are reassuring patients, especially in Sri Lanka, because here, whatever you say, a patient can go and see 10 consultants within the day, right? So unlike in other countries, where you are assigned to through the GP only to one unit. If you reassure, they will walk out of your clinic saying you are reassured. They will next day go to another person and get it removed. And you believe you have reassured the patient, and the patient is now having the lump and keep it quiet. It's not the same. It's not what is actually happening, right? So you should be able to follow up. You can get the contact details. It's a very tedious process, right? So if you really want to follow up your patients, reassure them, that's a very tedious process. What the radiologist mentioned, 20% chance that there can be multiple in the single breast or multiple bilateral multiple lumps. So we are coming to that.
Yes. Right. So I think our consensus might be above 40. If the lump is increasing in size, clear indication for surgery. Then apart from that, others are mainly based on our clinical judgment. And about the size, I think when we come to phyllodes, we can have another argument on that, on the discrepancy of the sizes that we decide to operate. So just for completion's sake, assume that we have taken this patient's fibroadenoma out, surgery has been performed, and Charisma, would you like to give us a small input on the gross pathology? Charisma, if you can speak to the mic.
Well circumscribed lump, which has got like a very bosselated type of appearance, and the cut surface is quite myxoid, but there are other times that it can be a bit fibrous, but this is what you exactly see on a macroscopy for a fibroadenoma.
Right. And then the pathologists make it a bit more complex to us, makes the matters worse by subclassifying fibroadenomas and sending reports. So I'm going to corner you, Charisma, and tell us, so rather than saying it's just a simple fibroadenoma, why do you go on classifying it as cellular fibroadenomas, etc.?
So, well, cellular fibroadenoma actually is quite it's quite commonly seen, and the terminology that we use for cellular is not because of the epithelial component, it's the stromal component. So normally the stromal component of fibroadenoma is mixed, it's quite myxoid, it's paucicellular, but in cellular fibroadenoma, it tends to be mild and diffuse increase in the stromal cellularity. So then we look for mitosis and atypia. Problem arises when we get core biopsies and we get a very minimal component of epithelial, and you get only the stromal component. And then the clinician wants to know what exactly it is. In those cases, because we know that fibroadenoma does have this intracanalicular pattern, so you can have this leaf-like, frond-like architecture, which is characteristically associated with phyllodes. So in that case, what we do have to give a differential. So we say that it could either be a cellular fibroadenoma or it could be a benign phyllodes. So you'll need a bigger or a wider excision for us to figure out what exactly it falls in.
I think one of the indications for fibroadenoma excision is also, if can you say cellular fibroadenoma in FNAC?
FNAC, no. So that's the thing. A lot of you all, and I'm glad that surgeons here love to send biopsies, which makes the pathologist's life easier. But unlike them, some don't have that option. So they keep on sending cytology. Now, cytology is a hit and a miss when it comes to cellular fibroadenoma or phyllodes, because it depends on the stromal fragments. Without the stromal fragments, if you don't see a cellular stromal fragments, if you don't see reduced cellular component, and all, it's very difficult. So for these cases where you think clinically it could be a phyllodes or it could be a cellular fibroadenoma, it looks different from a normal fibroadenoma, I would say go in straight for biopsies or a histological evaluation?
Clinical point of view, I think I have seen guidelines recommending excision of cellular fibroadenomas because they grow like phyllodes. Apart from that, I think clinically, do we have any, does it bear any significance? Then charisma, it comes to, then you all report them as complex fibroadenomas.
Complex fibroadenoma is when it fulfills a certain criteria. So if we have cystic changes which are more than 3 millimeter, we get these adenoses, which especially closing adenosis, where basically it's a proliferation of the glandular component and you have sclerosing bands going in between, or you see microcalcifications, or sometimes when you see these ducts and all, they are lined by cells which has got apocrine metaplasia. So apocrine metaplasia is basically when the cells become much more pinkish. So it has got prominent eosinophilic granular cytoplasm. So you get a papillary apocrine metaplasia. So those 4 components, if either of the component is present, we call it a complex fibroadenoma.
Right, thank you. So just few questions to the audience. What is a giant fibroadenoma?
So if the size is more than 5 centimeter, it's as a
Considered.
giant.
And overall, if somebody asks you what is the risk of a fibroadenoma converting into a malignancy?
So that's it's earlier said it's depend on the age
Okay,
of
so this, let's say 20-year-old female with this fibroadenoma, FNAC is co-biopsy is fibroadenoma.
Can a fibroadenoma become malignant? A confirmed fibroadenoma become malignant, not a bilateral lesion being malignant.
Yeah.
A confirmed fibroadenoma, today it's confirmed with, let's say, co-biopsy. In the future, can it become malignant?
It's very rare, but it's less, around 1%.
I think that is the association. When you excise a fibroadenoma, in about 0.5 to 1% of patients, you see an associated malignancy component. I think the answer is no. The fibroadenoma doesn't get converted to malignancy, but you have seen rare occasions where it is seen concomitantly with the fibroadenoma. Am I right?
Yeah.
Yes.
So when you're reassuring, therefore, it's important to clearly tell the patient that it is not malignant and it is not going to become a malignancy in the future. That is one of the questions patient have. Make a cancer පිළිකාවක් වෙන්න පුළුවන්ද? No. It can never become a malignancy if you have confirmed. So the 3 things that you need to mention in your reassuring is 1, it is not a malignancy, you're absolutely sure. There is no risk of it becoming malignant or it increasing the risk of somebody developing a malignancy. Third thing, the majority, like Nalinda mentioned, about 40 to 60% do go down in size over time. This is important, especially if you are planning on following these patients up. Non-intervention. You highlight these points and clearly tell the patient it is not a malignancy, it will never become malignant, it doesn't increase the risk of malignancy, and majority do go down in size over time. So there is no risk of fibroadenoma becoming malignant. I think actually an associated malignancy is probably even less
Yes.
than 0.5%.
0.5%, yes, very low.
We hardly see that.
The next question, these are common questions they'll ask, and I think the panelists have already answered. Can they resolve spontaneously? Yes, you can move the mic to the other.
As we discussed earlier, 40 to 50% of the fibroadenomas can resolve.
Can resolve. Can 25% will remain the same, I think, yes. And I think this is unfair to ask the audience about the place of microwave ablation. I will direct that question to the panel. What do you all think? My understanding is...
Again, I think there will be different waves. Personally, I don't believe in microwave ablation, probably because I'm a surgeon as well. The reason you need to ask the question, why? Why do we need to do? So when do we remove these fibroadenomas? We discussed some of the indications. One is a very large one. Microwave ablation probably won't be good enough because this is big and we have a doubt whether this is something like a phyllodes when it comes to a giant fibroadenoma. So the microwave ablation will not give us a histological diagnosis. Second thing, a small one like what we discussed. Anyway, there's a significant chance it will resolve spontaneously. So therefore, if at all the place of microwave ablation is very limited, and if you look at the cost, removing a fibroadenoma under local anesthesia is a 5 to 10 minute job. Microwave ablation costs a huge amount of money. It's a very expensive exercise as well. So therefore, looking at all those things, for me, it doesn't really sound correct, especially in our context, unless the patient is very worried about a scar and still wants to get rid of the lump.
So I think I don't entirely agree. I mean, I agree and disagree with. So the definite advantage is if it is in the periphery or it's in the upper inner quadrant where it's visible, you can avoid a scar with microwave ablation. But that is, as he correctly said, microwave ablation is only effective if the fibroadenomas are less than 2 centimeters in size, if I remember right. So it's for a small fibroadenoma where it's not clinically indicated that we are going to intervene. But if the patient asks for a scarless surgery, an option in today's day and age, if it is less than 2 centimeters, maybe we might have to give that option if the patient is quite can afford it. But the decided disadvantage, that is why it's not recommended for lesions above 3 centimeters, is we don't get a histological report of what is the lesion. So for lesions more than 3 centimeters, the current recommendation is they prefer surgery over microwave ablation to get a histological diagnosis.
Better to do a co-biopsy and confirm it's a fibroadenoma.
Yes.
Even if you are subjecting.
That is true.
Microwave ablation has its own place, a huge place for liver lesions.
Yes.
But you can apply it for everywhere, right? So I also personally, I'm somewhere in between you and Sanjeev. So there is no straightforward answer to this. So there is even if you ask this in the exam, so you open your view and discuss. So there's several treatment options. You don't say there is no place for microwave ablation. There is a place for these other criteria, but the preference is for these the lesions more than 3 centimeters is excision if you want to get it out rather than ablation.
As you mentioned at the beginning, these are benign. They are not cancers. So the management options are variable. Personal preferences are highly variable. You can see 3 of us have different views. So like what Nalin mentioned, important thing is understand and be aware these are available and their limitations, advantages, disadvantages. So if you get a patient, you can discuss. We have our personal preferences. Same for the thyroid. Last Monday, we had the same discussion at Thyroid Day about microwave ablation for thyroid nodules. I'm absolute against that also for various reasons. But some people recommend that. It's perfectly okay in a rare situation where the patient wants to avoid an operation and also get rid of this visible nodule. But it has its own disadvantages. Same in the breast. So personally, I feel the indications are very, very, very limited. But others have different views. Perfectly okay.
Sandipani, have you answered? Sorry, yes.
Yeah, I mean, of course, you will be clueless. You don't have anything after microwave ablation, right?
I say it's advisable, isn't it? Definitely.
To have a co-biopsy.
Sandipani, have we answered your question, or do you have anything to add to that?
Examination, the radiological assessment, and there's no psychological assessment is not there. So, or biological assessment.
Sir, do we need to mark before the ablation with the tips?
So reactivation is over. And also there are certain complications, especially superficial fibroadenomas. Skin necrosis is a potential complication. They create the additional area around the lesion by injecting saline, but still superficial lesion, skin necrosis, need to warn the patient.
Yes, microwave ablation, we use microwave energy to generate heat and that coagulate and shrink the fibroadenomas. Actually, the patients, some patients prefer to go ahead with microwave ablation due to scarring and rapid recovery and all those things. In my point of view, patients are having that more than 10 to 15 fibroadenomas. Their worry is the number. So sometimes we prefer to go ahead with ablation, microwave ablation in those patients because unnecessary multiple scarring would be there. So it's my view, but we have to have a that according to patient preference and the surgeon's guidelines, we have to go ahead with their management.
Thank you. So any questions related to fibroadenoma before we move forward? Yes, Minidu?
Smaller ones, yes. The smaller ones, yes.
1 second, Minidu. Yes.
Yeah.
From memory incision, it will rest of the major underneath all the lungs. So it's lost scar. Pain wise also it's much better. Chronic pain is also less than multiple scar. Which can go with accident incision having the scar. So there are options. Surgical also there are options. But surgeries, I'm not saying there's no place for microabrasion. There is a place. Place is limited at the time. For smaller lesions, smaller lesions, especially at the first place, multiple lesions.
Multiple lesions, yeah.
Based upon the words, that's fine. That is very important.
Thank you. Yes, Minidu, you had a question. The question is whether complex fibroadenomas or giant fibroadenoma is a clinical diagnosis. Phyllodes, yes.
There was not a cancer really. So not the typical carcinoma that we are talking about. That is why the large ones, pathology, they sometimes, when we do a core biopsy, they say highly cellular fibroadenoma or Periphyllodes, excision recommended or histological assessment recommended. In those situations, we can go ahead and remove these to be absolutely sure we are not missing a Phyllodes tumor.
So you asked about the complex fibroadenoma as well. So what Sanjeev told is that the phyllodes, even we said we are not doing in cytology, we prefer core biopsy. But when it comes to phyllodes, even core biopsy is not good enough, right? So the pathologists cannot confidently rule out whether it's a phyllodes or just a fibroadenoma. So that's where the place you come for excision biopsy. And phyllodes, I think we will be discussing later. Complex fibroadenoma, theoretically, if you see the data, the relative risk is ranging from 2.3 to 3.3, different studies. Whereas a simple fibroadenoma, the relative risk is 1.6, which is almost the same as the general population having a breast cancer. So theoretically, if you want numbers, those are the numbers, right?
Is a multiple fibroadenoma.
No, depending on what the radiologist says or at your clinical assessment. So if you have suspicious lesions, you can do the biopsies, right? So the entirely benign lesions clinically as well as radiologically, you don't have to do multiple. If you have 10 lesions, you don't have to biopsy each and every lesion. You don't.
And if somebody has more lesions, probably we can have a lower threshold to biopsy unless there are any lesions, like Lalinda said, that carry features suspicious of malignancy on ultrasound scan.
We do regular scans on those patients, and if there is interval increment in size, yes, we are go ahead with the biopsy, the particular lesion at all.
MRI is for younger breasts, right? So anyway, the younger people less than 35 will be having these multiple bilateral fibroadenomas. I can't say there is no place, but if you have the facilities, you can do. But whether the criteria is if the patient is radiologically and clinically benign, and there is no other risk factors for her to develop a breast cancer, you don't need to do a MRI. If you think that the patient is having other risk factors also, family history, then you can do a MRI.
So typically another situation that we encounter is somebody comes with a fibroadenoma, radiologist does a scan and say there's an area that is not clearly visualized, doubtful appearance. We know a young woman, there is very little place for a mammogram. In those patients, we may go for a MRI scan. Not if we clearly visualize a fibroadenoma or fibroadenomas and rest of the breast is pretty much normal. In that situation, I probably wouldn't do MRI. But if there any indeterminate area, or if there's an area where the radiologist cannot visualize adequately or clearly, we may do a MRI scan.
Yes, actually, we have limited resources for MRI as well in Sri Lanka at the moment. So I agree with the surgeons. We do the indeterminate cases with the background history positive. Yes, we have to go ahead with MRI. Otherwise, no need.
Then shall we move on from fibroadenoma to I think you've got a comprehensive knowledge on that. We'll move on to the next case. It's a little similar. You can note the differences. There's a 42-year-old female presenting with a lump in the left breast for 3 months duration. And when you examine, let's say it was a 5 by 5 centimeter firm lump in the upper outer quadrant. Who's next? Yes. So what are your impressions about this, your thoughts?
She needs a complete triple assessment.
Okay, sorry. So let's say 8 by 5 and that's the clinical picture.
Definitely, I'm going to proceed with ultrasound scan of the breast and followed by mammogram.
What is your clinical impression before you go for investigations? Your clinical diagnosis, what is it likely?
I'm probably thinking of a malignant lesion considering the age and the appearance.
Right. Anything else?
Can be a cystic.
Yes, it could be malignant. Is there anything else?
Cystic lesions.
Cystic lesions. Say it's, could it be a fibroadenoma?
Still, yes.
Anything under the sun is possible, isn't it? But what is more likely along with malignancy if it's a large mass of this size?
Probably a cystic.
Which has, yes? Anything else that goes hand in hand with large fibroadenomas?
Phyllodes.
Phyllodes. Could this be a phyllodes? You're right, it could be a cancer as well, but this could very well be a phyllodes as well. So what would you do?
I'll complete the triple assessment, do the ultrasound and the mammogram followed by a core needle biopsy.
Right. Sandipani, would you like to? So this is the mammogram done in this patient. Now do you think it looks like a malignancy?
No, more of a benign lesion.
It looks more like a benign, large benign lesion. Yes.
Yes, this is MLO views of bilateral breast mammograms. There's a huge, well-defined circumscribed dense mass in the left breast. And we can't see any microcalcifications or macrocalcifications in it. And there that typical feature is there could be a halo at the periphery of the lesion. Then we have to correlate with the ultrasound. Yes.
So I think it's we just if you can discuss these lesions and tell me which one looks like a fibroadenoma and which one does not. And
ultrasonically, it could be similar to fibroadenoma, but there may be different features like heterogeneous internal echo texture with cystic areas, solid areas. There could be internal vascularity, and the characteristic feature is posterior acoustic enhancement. You can see in the first image. Here, that is the posterior acoustic enhancement. Here, that heterogeneous echo texture and ill-defined margins. This is the typical fibroadenoma, well-defined margin. Here also that heterogeneous echo texture with the posterior acoustic enhancement.
I guess we'll all agree we'll go ahead with an ultrasound guided biopsy, isn't it? Officer, right. So we do an ultrasound guided biopsy and it comes as a phyllodes tumor. To get an idea about the pathology behind it, I'd like to invite Karisma just to give us a brief overview before we go into the discussion.
As seen on the screen, so you have what you call intralobular stroma. So those are the ones which proliferates and leads on to a biphasic tumor, which can either be a
If you can get the mic a little closer.
fibroadenoma or a phyllodes.
Shall I move?
Yeah. So as mentioned earlier, cytology has no role. Biopsy is also a bit doubtful. It's the excision which makes all the difference, because in the excision, you see the proper architecture where you see this very prominent intracanalicular pattern which gives rise to this leaf frond-like architecture. And when you look at these epithelial component, it is benign. So benign is always with epithelial and non-epithelial lining, which is the dual epithelium. And the stroma is the one which is hypercellular. So with the stroma is what we decide whether it's going to be benign, borderline, or malignant. Out of the features that I mentioned, we talk about atypia, which can be mild to moderate to malignant, depending on which one it is. Mitosis is the one which we really rely on, most of the pathologists, because that is more accurate for us. And also there can we talk about stromal overgrowth and all, which is seen basically more in malignant. So what does stromal overgrowth mean? It basically means when you look at it on a particular field, you will see that you will only see the stromal component because of the abnormal proliferation, and you don't see the epithelial component.
What is the clinical significance of phyllodes compared to fibroadenoma?
So it's like a sarcoma. If it can give metastasis.
Or is there like a disease spectrum when it comes to phyllodes?
So it's benign to malignant range is there.
The phyllodes in this patient. What is your name?
So I'll discuss with the patient and I'll go ahead with the mastectomy if the lesion is large enough, or else I'll excise the tumor if the reconstruction is possible. And
Next person, do you agree with that management?
So I'll anyway discuss with the patient, and it's a benign to malignant spectrum is there. So if it is benign or borderline malignant, we can go ahead with a 1 to 2 centimeter macroscopic.
How do you know whether it is benign or borderline or malignant? With the core biopsy, can you confirm that?
No, sir.
So how are you going to decide your management based on that then? Because you will not know that information before the surgery. Sometimes we are not sure whether it's a phyllodes tumor before surgery. All that we have is a doubt. Pathologist says possibly cellular fibroadenoma, stroke, or slash phyllodes tumor. Or sometimes they say clearly a phyllodes tumor, but maybe borderline, maybe benign, maybe malignant. Not a very conclusive diagnosis. Okay. So how will you manage?
First, we'll go ahead with the excision biopsy. Depending on the findings, then.
So excision biopsy like for fibroadenoma or a malignancy?
No, sir. With a 1 centimeter macroscopic margin, we'll do the excision biopsy.
For all situations I mentioned, or selectively? Now I mentioned sometimes we don't have a diagnosis.
Yes, sir.
Sometimes we have a confirmed phyllodes, but we don't know whether it is benign, borderline, or malignant. So all will have the same surgical approach or different surgical approach.
I'm not sure.
Next one. Or anybody? You understand the question, no? Sometimes we have a doubt whether this is a phyllodes. Sometimes phyllodes is confirmed, but we don't know what type of a phyllodes tumor it is.
Shall I put it in a practical setting? So this is actually a patient that we are now trying to manage. The histology has come as could be fibroadenoma or benign phyllodes in a massive lesion. And so what should we go ahead with now? You can, I don't know whether you can see it properly. It's almost taken 80% of the breast. So that's what you're asking, isn't it?
Probably no. Again, I think there will be variable approaches. I personally would, if it is a confirmed phyllodes, I would do a radical surgery. Radical in the sense, a wide local excision, or in this situation, I think there is nothing short of a mastectomy with or without a reconstruction. Even other situations, most of the time, in real life, the phyllodes are fairly big tumors. You have to do a wide excision. Final pathological clearance should be 1 centimeter. So if we are to get a final pathological clearance of 1 centimeter, we need to remove about 2 centimeters. For malignancy, we want a 1 millimeter margin, or no ink on tumor, we go for a macroscopic 1 centimeter. That is how we achieve this no ink on tumor 1 millimeter. So if you have to get this 1 centimeter microscopic clearance, you have to go for a much bigger macroscopic clearance. So if the lesion is 5 centimeters, you remove 2 centimeters on either side. That's you are thinking of a 10 centimeter kind of a lesion removal. That means it's a mastectomy, or if not, if you are going to do a wide local excision, the patient will require some form of a reconstruction. So that you need to discuss with the patient, whether it's a mastectomy or a wide local excision with a reconstruction. In the first scenario, if the diagnosis is not confirmed, I probably wouldn't be that radical, because always you have the option of going back and removing the margin for adequate clearance. So I would probably change my approach in the 2 scenarios, because I don't want to do a radical operation even without confirming that it is a phyllodes tumor, because after excision it comes as a fibroadenoma, we don't need any further treatment. But if it comes as a phyllodes, in that situation, I probably would go back and do a wide excision to achieve a margin. And some situations what we do, if we are not very sure about the margin, we may not do the reconstruction in the same setting. We remove the tumor, wait for the pathology report, make sure we have achieved adequate resection of 1 centimeter, and then plan for a subsequent partial or a full reconstruction. That is also an option. Again, there will be a lot of different approaches. That is how I would approach it. I would like to know.
Yeah, the what you mentioned, the already said the benign of phyllodes or a fibroadenoma, but you had in your hand.
Okay, yes.
Right. So that's a bigger lesion. But if it is says benign phyllodes or a fibroadenoma, I wouldn't go for a mastectomy. I would go for because if it is a benign phyllodes, what you need is an excision biopsy. So I will do it at a 2-stage procedure. I will do the excision biopsy only, not taking any margins. I will wait for the, you can even fill the cavity with saline and keep it patent. And then after the assessing the, going through the histological analysis, I will do what is necessary. If it comes as an intermediate or a malignant, then offer a mastectomy with reconstruction. But if it is still benign phyllodes, I will leave it as it is, because this benign phyllodes, once you remove, it only pushes the parenchyma. It doesn't invade the parenchyma. So everything falls into place, and the skin also settles in. So we don't have to do anything later. But the other case, if it is not proven, still it will be a 2-stage thing. I would go for an excision biopsy, because if you want to do a mastectomy, this is there will be differences. If you want to do a mastectomy, you can always do a mastectomy and reconstruction, or without reconstruction. If it is not proven also, still I would go for a excision biopsy, the entire lesion, then subject to histological analysis, because malignant phyllodes it's not common, it's rare, right? And I don't know, the pathologists might be able to give if it. Can you say it's grossly malignant on a co-biopsy? Phyllodes, yeah.
Rarely we get that type of pathological diagnosis, but I have another issue now. This is a practical problem. Now, I have come across several patients where the initial pathology was a benign phyllodes. So we remove, not with a 1 centimeter margin, and final pathology, clear margin.
Can I just interrupt you 1 second there, so just to clarify them? So the initial surgery, both of you are in agreement we should go for an excision. Is it just a diagnostic excision of the lump, or are we doing a wide local excision with a 1 centimeter clearance in the initial surgery? You will do an excision. Okay.
Yeah, so that is what I'm going to come to. Now, I have had several patients where initial excision done with clear margins, benign phyllodes, but coming back with either malignant or borderline recurrences. Even last week, I had a patient like that, operated 1 year ago for a benign phyllodes with very good clear margins, came with a rapidly growing lump. I thought it was malignant. I did a wide local excision with a reconstruction. Now with a 1 centimeter margin, part of the skin also had to be compromised. It has come as malignant phyllodes now. There have been several patients like that where initial diagnosis was a benign phyllodes, but they come back a year or a few years later with malignant recurrences, either borderline or malignant recurrences. I don't know, evidence really doesn't suggest that. But because of that, I'm a bit scared now just to leave benign phyllodes, like what Nalinda said, although I also have been practicing it like that. These may be relatively rare occurrences, but for last few years, I have seen a fair number of patients where I had to either do a mastectomy or a fairly big excisions with reconstruction. So malignant recurrences of previous benign phyllodes tumors where the tumor had been removed with a clear margin. So that is one problem I have encountered, not really supported with evidence, however.
So if you look at the yes.
I agree with you, but that my belief is you can always go back and
Go
do
back.
a surgery if you're going to do a mastectomy. Problem is, if you have done a mastectomy, on top of that, a reconstruction for entire benign lesion, in years down the line, one fine patient might come and sue you. Right? Yeah, these are possibilities. Right? So, because you have done a mastectomy for a benign lesion.
You have a question, is it? Yes. So
It's just like a fibroid now. You don't have to take a mask.
So I put up the NCCN guidelines. You can clearly see what they say is if it's just a benign, just excision biopsy, no margins. But if it comes as borderline and malignant, they need a 1 centimeter margin. And yes, you had a question. Yes.
But with precancerous, they don't become carcinomas. But the problem is what we discussed. A benign phyllodes may come back as a malignant recurrence of a phyllodes, not a carcinoma as such. So again, the problem is, now we will definitely know whether it is benign, borderline or malignant only after excision. Very rarely only we will have a confirmed pathological diagnosis of a malignant phyllodes or a borderline pre-op. So that is another problem. Patient will require 2-stage procedure like what Nalinda mentioned.
And also there's a place for MRI. If you are not happy, before embarking on a major procedure, just go for an MRI assessment as well.
So this brings us to, I think we had a dispute on what's the cutoff size for excision of fibroadenomas. So in the NCCN guidelines, they take large size as more than 3 centimeters. But that is if you are suspecting it as phyllodes. But I think there is no cutoff for fibroadenoma. So 3 centimeters is what I take as the based on this, but I don't think they don't have any guidelines giving us a cutoff for the size for fibroadenomas. Anything you want to add, Sandeep?
Yes.
Sandipani, one more thing I want you to answer. What's the place for contrast enhanced mammograms in these kinds of patients? Because we generally see phyllodes in young females.
Yes, there is a place. It can show that rapid contrast enhancement as if there is a malignant features with washout. MR also in kinetic curves, we can assess with the kinetic curves whether it is malignant or not.
Right. So let's assume that this patient underwent surgery and had a benign phyllodes and is now in follow-up. Any questions related to phyllodes?
Sarcomas also a differential for this appearance.
Yes. Is it in the malignant phyllodes? They behave as...
When we get core biopsies and you get a malignant phyllodes, it's easy for us to say it's malignant. And we can only say it's a malignant phyllodes provided we get a component of the epithelial, a glandular component which looks benign, then we know for sure it's a malignant phyllodes. But if you're getting only the stromal or the sarcomatous component only, then it could be a harangue of differentials along with metaplastic carcinoma also. So that's when we'll have to do all the immunos and all and confirm.
Right, sorry. So we'll move on to the third case. If you don't have any questions on that, on phyllodes. So another fresh topic, 42-year-old female presenting with a lump. And this time you feel a 4 to 5 centimeter lesion, which is soft to firm. Could be anything under the sun. So obviously we are going to go ahead with imaging. Let's see what the imaging says. Sandipani, would you like to?
So the well-defined lesion, similar to that surrounding breast parenchyma. it is faintly seen, which has mixed echogenicity, hypo and hyperechoic areas. But if we do mammogram, we can have.
Do you want your mammogram, Sandipani? Yes. She doesn't like my mammograms, the ones I have put. 1 second. Is it, sorry. This one is, yes.
Yes, that is the one. It has the typical appearance because this is hamartoma, which contain glandular tissue as well as fat tissue. It shows hyper and hypodense areas on mammogram. The typical appearance is breast within breast appearance. Can you appreciate it? These are the two lesions. These dense areas and hypodense areas. Here also will define dense and hypodense areas. This is the typical appearance of a hamartoma.
Right. So the next, is it you? Yeah. So you get this ultrasound scan and the mammogram, which clearly says this is a hamartoma. What is your next step?
Since it's a benign pathology, I would go on with surveillance of the patient 6 monthly with an ultrasound.
Just give me 1 second.
Would you do a biopsy? Would you do a co-biopsy? The radiology report comes as?
If you, yes.
Most likely a hamartoma.
In a 42-year-old female.
Yes, in that case, given the age and the risk of malignancy, I would like to exclude the possibility of a malignancy with a co-biopsy.
Typically, they report this as a BIRATS2 lesion. So that's confirmed benign. So not essential to do a biopsy unless there are other reasons. So generally, we no need to, no biopsy unless the patient really is worried about it, no indication for surgery. I generally wouldn't follow these patients up as well because it's a complete benign lesion. Unless, Nalind?
These are rare occasions, right? So I have seen for the past 6 years only, less than 5, right? Less than 5, right? So I would do a biopsy. I don't come across a radiologist giving BIRATS2 on this. They say either 2 or 3. So I will do a biopsy, and if it is confirmed, I will leave it alone.
If you do feel a lump, isn't it safer to go ahead with a biopsy anyway? Because they anyway feel like a lump to the hamartomas.
Yes and no, both. I don't know. NHSL, they are generally quite good with our reporting. So always the hamartomas, they report as BIRATS2. We discuss in our MDT. And if they are confident that it is a hamartoma, BIRATS2, in our practice, we don't do biopsies. We just reassure and discharge the patient without any follow-up.
I guess we have to agree if it comes as BIRATS2, the guidelines clearly state that we don't need to go for histological diagnosis. If they say that, then we can safely avoid. But
Yes, 2 definitely, because that hyperechoic areas, the differential would be lipoma. Actually, that if there is a hyperechoic area, that is fat content, that most probably benign, I will give a BIRATS2.
Pathological point of view, what would you see if we have done a biopsy in a hamartoma?
Basically, in excision might be better because you'll see the architecture where you will see basically the normal occurring mammary tissues, which can be your ducts, your lobules, your fatty tissues, and fibrous tissue. It just organized in it basically is in a disorganized growth pattern. And the stroma will be quite collagenous. Sometimes you can get a chondroid metaplasia. So depending on which structure is more prominent, we can further classify it into, let's say, an adenocarcinoma if we see that the glandular structures and the adipose tissue is more prominent. Or we can sometimes classify it as a chondrolipoma if we see that the chondroid metaplasia and the adipose tissue is more prominent than the glandular component.
Yeah, that made it clear to me as well now, all that, yes. So, but anyway, regardless of it, we can manage conservatively, isn't it? Right, thank you. So, simple, straightforward case. We'll move on to the next case. Case 4. So this is again a 45-year-old female presenting with a left nipple discharge, which she has noticed sometimes to be bloody, sometimes to be serous. And you examine and you were on compression, you notice a blood-stained discharge from one ductal opening. How would you assess a nipple discharge? Or would you have?
Next person.
Since this is a 45-year-old female and had a bloody discharge from the single duct, it's a suspicious. So I'll go ahead with the triple assessment, sir. Thorough history and examination and family history as well. And I'll do a mammogram and ultrasound scan.
Can you explain a little bit more on how you assess clinically the nipple discharge, apart from
So,
what other things that are worrying, apart from the color?
Apart from the color, it's a single duct discharge from one breast, single breast. So it's a suspicious, and I have to go ahead with the other. It's a express or it's a spontaneously. The duration and all those things.
Unilateral, single duct, and the color are a little suspicious. So you'll go ahead with investigation. Sandipani, so we have done a scan.
This is the lesion. It is cystic lesion. It is, sorry. It's a complex cyst, actually. There's a cyst, and within the cyst, there is a solid area with the vascularity, and there could be a vascular pedicle here. And this is the fluid outline due to it is within the duct. Usually it is 3.3 to 3.5 centimeter away from the nipple. If there are multiple, more than 5, we call it papillomatosis. And on mammogram, we can see.
Have you brought a mammogram, Sandeep? Sorry, I put it. So this one is?
Yes, this is the ductogram. Yes, we have injected contrast. If we can see the solid area, here it is as a filling defects. This is the dilated duct. This is the filling defects where the papilloma has arisen. On mammogram also we can see small dense area in the mammogram.
So the ultrasound scan and mammogram are suggestive of an intraductal papilloma. What would you do?
Then I will go for the histological assessment. Guided fine needle aspiration for that.
What are your thoughts, the panelists? So he wants to go ahead with the ultrasound guided, sorry, FNAC.
Okay.
IFOs agree.
It will depend on the size. Most of these are tiny lesions and they are too small for a co-biopsy. Most of the time, fine needle aspiration. So 2 questions. Okay, fine needle aspiration comes as a papillary lesion. What is the management?
It's a benign condition. So in that case, I will do my surveillance.
What is your surveillance?
6 monthly. You can assess ultrasound.
Next person, do you agree with that management? This is a 40-year-old who had come with a blood-stained discharge. Ultrasound, mammogram is suggestive of papillary lesion or papilloma. FNAC is also papillary lesion.
It's a duct excision. I will go for the duct excision.
Why?
Because it's a 45-year-old.
Let's say she's 35.
It's 35-year-old. If troublesome symptoms, then we can go the duct excision.
What is troublesome and what is non-troublesome?
He's being diplomatic.
This
is a single duct blood-stained discharge.
And spontaneous and affecting the daily living activities.
How can it affect daily activities?
There's a spontaneous.
Okay, let's assume it's not affecting the daily activities.
Yes, then I will for this biopsy and the surveillance if papillary.
Agree. Next person.
I think the exam batch is in front. Do you have any different?
Front people.
Do you have different?
We'll start from. Would you agree with that management? It is not available in most places. Okay. Okay, so in general, as a principle, if somebody comes with a bloodstained nipple discharge, we have seen a lesion like this, we cannot still exclude a malignancy. Okay, 98 or 97% of the time it's a papilloma, but we cannot exclude what you call a papillary carcinoma. I think you agree. So therefore, an excision is a must. Right. So some form of excision, type of excision will be dependent on the age. You can either offer a microdocectomy, or in an old person, you can offer a radical duct excision, what you call Hadfield's procedure. Slightly different question. If there is no lesion on the mammogram or the ultrasound, that is another common scenario. A woman comes with a single duct bloodstain discharge, imaging absolutely normal. What will be your approach? Yeah, but still surgery, because we cannot exclude, because differential diagnoses are papilloma, carcinoma, or DCIS. Those are the three differential diagnoses. We cannot exclude any of those without an excision. So anybody, therefore, I think I have seen a few patients where bloodstain discharges had been managed conservatively. I personally never manage a bloodstained single duct discharge conservatively. I always offer a surgical excision irrespective of the imaging or FNAC or a pathological diagnosis. Surgery, of course, will vary. If it comes as a preoperative carcinoma, it will be a wide local excision. Otherwise, at least a microdocectomy, because we cannot conclusively exclude a malignancy in this situation. So,
I agree with you, complete. So you don't leave it alone. So nipple discharges, 3 red flag signs apart from the color. Color comes lower than that. Unilateral discharge, single duct discharge, spontaneous discharge. Breast cancer can present in any color. It can be whitish, milky, watery, yellowish, blood-stained, whatever the color, breast cancer can come. So those are the 3 red flag signs. And if there's a single duct discharge, if there's a lesion that you can visualize, go ahead and do a excision biopsy, right? If you can't see, I would do a MRI before doing a excision biopsy, just to see whether there's anything sinister going on, to have some idea, because after surgery you can't do it. So I will do MRI before that. Otherwise, I will agree with Sanjeev.
So to make it clear, intraductal papillomas are benign, but there is an association with malignancies, I think less than 3% or so. And to make sure that we don't miss them, we will go ahead with a proper diagnostic excision. And this is a new topic, papillary breast lesions. Charisma, would you like to brief us a little bit on, there are many types, I mean, again, the pathologists like to...
Can I just comment on the
Sorry.
pathology and then we'll go back to this?
So where do you want me
okay?
to...
Right after this.
Right after this? This one? Okay.
So when Dr. Kanchana asked you all what the management was, in my head, I was like, don't say cytology, because papillary lesions is one of the most difficult diagnosis on cytology, primarily because you don't get the cells. This is a very rare occasion where you'll get something which is like a papilloid clusters like this, where we get happy and we say, okay, it's a papillary lesion. But other than that, mostly what we detect is basically cyst macrophages, or not even that, just amorphous eosinophilic material in the background with no cells. So you'll have to go in for histological evaluation. But now I realize why you all don't send biopsies and you send cytology. Okay, so when excision, what we see is cystically dilated ducts with a papillary lesion which has got this thick fibrovascular core. And when you look into the lining, again, it will be a dual epithelium with dual lining with epithelium and a myepithelial layers. Why excision is important rather than going for all those is because in terms of intraductal papilloma also, there can be cases where you can have one side completely benign and you can have the other area either having a atypical ductal hyperplasia or a DCIS. So that's why the importance is for the entire thing to be taken out. So that is just the epithelium. Can we go back to the slide before? Qualify. So that's how we qualify it. So that's why intraductal papilloma needs to be taken out, because you'll have areas sometimes which has got the ADH or a DCIS. So we all know that between ADH and DCIS, the differentiation is in terms of the size, which is less than or equal to 2 millimeter or more. And also other thing is that with papillary lesions, it can either be in situ or it can be infiltrative. So with the in situ ones are usually the papillary DCIS or the encapsulated papillary carcinoma, the solid papillary carcinoma. All these things, if we do the myepithelial layers in the especially with papillary DCIS, you will see that the myepithelial layers will be absent within the lesion, but it will be present in the peripheral duct. Whereas in this, and why we need to extensively sample any of these non-invasive papillary lesion is because there might be a component of invasion. So in those cases, we will miss out if we don't extensively sample. So the invasive ones are the encapsulated solid papillary with invasion, or it can be an obvious invasive papillary carcinoma or an invasive micropapillary carcinoma. That's how we classify papillary lesions.
So papillomatosis is when there's more than 5%.
Yes, and usually central ones is usually single, and they say the peripheral ones are the ones which are multiple.
Yeah, so just for the panelists to comment, I just took this. So these are considered as red flags when if you get a malignant papilloma, the chance of it being malignant is considered higher if the lesion is larger, older age, more in the periphery, and if the radiologists have reported it with a higher higher score.
Yeah, but still the question is, if those are not
there,
can we still leave a lesion?
No, is it?
Still, we need to offer, or otherwise very close follow-up.
Yeah. So I think we have concluded our discussion on fibroepithelial lesions. Is there anything you need to ask beforehand?
Is there tea break?
Yes, should we go for the tea break now and then join in a little while?
Unless you have any more questions.
Yes.
Malignant, after excision, the final histology is malignant. Okay, so this is like a sarcoma again. We don't generally treat the axilla. So the management would be you need to have a clear margin, 1 centimeter like what we discussed. Still, if you are not achieved 1 centimeter clear margin, either you have to go for a re-excision or a mastectomy. Most of the time, mastectomy is preferable because you need to do a fairly radical resection. Then at the same time, you need to do a CT chest because this is a sarcoma. They tend to metastasize to the lung. So that is a management. And then adjuvant therapies, there are a few studies if you want to read about. They are looked at efficacy of radiotherapy, and then there are a few targeted therapies, but they are not very effective. So surgical, radical surgery is the most important thing with a 1 centimeter, at least a 1 centimeter final pathological clearance for malignant phyllodes. That will minimize the risk of a recurrence. Otherwise, they are notorious to come back with recurrences.
I agree with that, but if you are going to do a mastectomy, if the axilla is clinically and radiology negative, I would do a SNB at least, because sometimes there can be invasive epithelial carcinomas as well. So you can't go back and do it. So if you are going for a mastectomy, I will do that.
And thank you. Then shall we have a small break?
Yeah.
And sorry.
If a patient comes with nipple discharge, imaging-wise, if it is negative, are you doing direct smears from the discharge? No.
Yield is very limited. The positive yield of epithelial cells in nipple discharge is very limited. So a positive one certainly will help with your diagnosis and management. Just if it's negative, from what I remember, it's about 30 to 40%. So majority, there will not be any, the information will not be adequate. And if you read the literature, there are other approaches also for a person with a nipple discharge, bloodstained single discharge. You can do a ductoscopy. There's a 2 millimeter scope that you can introduce along the duct. With that, papillomas can be excised, but unfortunately, that is not available in Sri Lanka. And they are no longer being produced also, so no one can buy. Only the older machines are available. So that is not an option. Ductogram, we used to do, but nowadays that kind of has fallen out of fashion because better quality ultrasounds, availability of MRIs like Nalita mentioned, so they are good enough for us to ascertain that. Otherwise, it's a fairly difficult, tedious investigation. So then the management, blood stained, or if you have any doubt, either duct excision or radical single or radical duct excision, But if it is multi-duct, typical ductectomy, I think we are going to discuss
Yes.
that. So management may be conservative.
Then thank you very much. We'll have a small break, 15 minutes, and we come back for a few more cases. Thank you.
Now, Dr. Samara is also going there. She's also sending that. Now that the last had they'll need some development in that place. Let's be the most talked about scabies. ඒකයි අනිත් එක අර අභාගයේ පිළිබවාගේ ඉවසක තියෙන සිංහලක් දැක්කේ කාමාට. හරි. එයාට කියලා කියන්නේ.
All right, so we'll start again. Shall we wait for Nalinda? We'll start. Nalinda will come. So now we'll focus a little bit on inflammatory breast disease, which is again a common presentation. So this is the first case. A 45-year-old female presents with right breast tenderness and lumpiness for 2 months duration. And when you examine, apart from tenderness, you can't feel any discrete masses. I think who's next? Is it Minidu next or is it you, right? So, so basically the patient is having mastalgia. How would you assess mastalgia?
Considering the age, the first consideration is to exclude the malignancy. So,
All right. So on examination, there's no lesion. Is it a common thing that we encounter in this age group? Patients presenting with pain, tenderness, lumpiness. But when you examine, you can't find anything apart from tenderness.
history, we should concentrate on whether the mastalgia is cyclical or non-cyclical.
Yes. So let's assume it's a non-cyclical mastalgia. So would you go ahead with an ultrasound scan in that case?
Yes.
Without a lesion?
Still, I have to do an ultrasound scan to see whether if any unpalpable lesions are there.
Right. Just a question to Prof. Sanjeev. Would you do ultrasound scans in all patients who present with mastalgia?
Yeah. So my answer is no. So if a patient comes with just mastalgia and especially if it had been there for a long time or cyclical, we know pain being the presenting symptom of malignancy is very, very small, negligible. So in that situation, especially in the context where we have limited access to regular ultrasounds, I wouldn't do any imaging in this situation. If you are doing imaging, that's probably a screening investigation. Just before we reassure, we may do, but probably not on a routine basis, especially if the patient is young, typical cyclical mastalgia, bilateral mastalgia, pain gets worse just prior to menstruation. I wouldn't do any imaging. I would just reassure the patient and tell them this is a physiological situation, nothing to do with malignancy, and I would just reassure. But if the patient is very worried or they demand that we do ultrasound for additional reassurance, I may offer them, but not on a routine basis.
If the patient is above 40, having non-cyclical mastalgia and a tenderness only in a particular region, then
in that situation, I would consider not only ultrasound. In that situation, I would consider both mammogram and ultrasound. So it will be based on the clinical findings and the patient factors as well.
So you've gone ahead and done a scan. Do you want to discuss your ones, right? Yes, so you've gone ahead with a scan and a mammogram. And how would you?
This is the mammogram of a patient with fibrocystic disease. Actually, the accuracy is depend on the glandular tissue component. Here it is that density C, like heterogeneously scattered glandular tissues. And there are, in addition to glandular tissue, you can see density, scattered densities. That asymmetric density in the upper quadrant of the left breast. And meantime, there are a lot of calcifications. We can further assess the calcification. If we are suspecting fibrocystic disease, we can do two lateral view where there is sedimentation of calcification within the cyst, giving rise to teacup appearance. And we can move with ultrasound.
Do you have an ultrasound? Is it this one?
Yes. The first image, which shows there are three types of cysts.
Shall I come to this in a little while? Because we can ask them what. Is that all right? Thank you. So the ultrasound scan shows fibrosis and mammogram shows fibrocystic disease. What would you do? You can answer. I'll just try to get. So it comes as fibrocystic disease.
Provided that the patient's history examination, he has no risk factors, and that clinical examination and radiological investigation supports the diagnosis of fibrocystic disease. It's a form of aberration of normal development and involution. So it's a normal change in the breast characterized by fibrous and cystic changes. So I think if all investigations favor and there's no lumpness, discrete masses or so other thing, I think we can.
Do you need a histological diagnosis here?
Provided that there's any lump that is suspicious in biopsy 3, we might do biopsy. Otherwise, I think we can use it conservative.
You said provided there are no risk factors. So if there are risk factors, is your management going to be different?
That if he has strong family history of malignancy and strong positive risk factors for breast CA, like hormone replacement therapy, OCP or something like that, and if there's a discrete lesion which is suspicious in the mammo, then I would do a triple
Findings
assessment.
are for fibrocystic disease, so there is nothing suspicious.
Minidu, if at all, if it is suspicious and your clinical diagnosis is not compatible with ultrasound and mammogram, then what would you do?
Then I have to do an MRI.
Yeah.
And you mentioned something else. You said if there's a history of OCP, which is a major risk factor. Is that correct? OCP?
OCP is not a risk factor.
Yes, because you are the one who said
sorry.
risk factors, family history, OCP, HRT, those are things that were mentioned. OCP is not a risk factor, remember, because the studies are from 1960s and 70s when the patients were using higher dose estrogens. But nowadays, the current OCPs contain a minute amount of estrogen that is not considered a significant risk factor for breast cancer. HRT certainly yes, not OCP.
So in this situation, I think we can safely avoid a histological diagnosis and reassure the patient. And perhaps go into management of the mastalgia straight away with analgesics and so on. Just to complete, what would you see in a biopsy, Charisma?
So as the name suggests, fibrocystic, so you see a lot of fibrosis. So you have a lot of stromal fibrosis and you see the cystically dilated ducts and all with lumen secretions. They have these apocrine changes happening. So the main thing for us is always to look whether there is any malignant component. So we will always assess the lining of the epithelium, whether there is a dual lining. Sometimes you may even get intraductal papillomas and also you need to see whether there are there.
So what is the concern of fibrocystic disease, Minidu? Do you think there is a malignant potential?
As far as I know, it is essentially a aberration of normal development and involution. So it is, I think there's no malignant component.
What's the patient's concern? Primary concern is?
Mastalgia.
Mastalgia, yes. So any medications that you know that we can prescribe?
You can
Trial and error.
This evening primrose oil can be applied, and there's some say that the use of danazol, tamoxifen, and bromocriptine can be used, but I'm not sure about its efficacy and its uses.
Okay, so I generally advise against evening primrose oil for several reasons. One is there is absolutely zero evidence. It is not evidence-based. If at all, it's a placebo effect. Second thing, it's expensive. Evening primrose oil is a fairly expensive drug, not available from the hospital. Patient has to pay out of pocket if they're going to buy it. Cost few ₹100 a day. If you're going to give it for 3 months, that's a fairly substantial amount of money. So I wouldn't recommend that just for a placebo effect and expensive drug. So more often than not, especially cyclical mastalgias, you can manage with analgesics, paracetamol, NSAID, either systemic or local on a as required basis. In a very rare occasion where the patient has very severe mastalgia that is interfering with the day-to-day activities, I'm talking about maybe less than 1%, 99% of the time it's a psychological component. In a situation where there is severe mastalgia, tamoxifen is a drug of choice because it blocks all the estrogen. It's a wonder drug for mastalgia. Mastalgia will just disappear. I don't know, although in the literature they mentioned about danazol, bromocriptine, etc. I have no personal experience, but I know tamoxifen works very well.
So I have a very high threshold for tamoxifen. So reassurance plays a major part. So their worries, pain, and the back of the mind, the worries whether it's due to underlying cancer. So if you can reassure the patient, it's due to the hormonal changes, the breast tissue being sensitive to that. Then the patient asks, "Ithin doctor eka pattaka nitara ridena." Right? It's a very common question. So if you look at the evidence, 80% of these mastalgia patients experience pain only on one side, right? In that breast also, 80% only one area, one quadrant, right? So you can share this information with the patient for a proper reassurance. Once reassured, they will accept. Otherwise, they will keep on coming or they will do the consultation with different people because the pain is not settling. Evidence says if you give a NSAID gel to apply, 50 to 70% will settle on its own. On top of that, you can add paracetamol, Panadine, those analgesics. Some papers say even high-dose vitamin E helps to counteract the mastalgia pain. And I have seen patients, not in this country, who has done bilateral mastectomy for mastalgia. 20 years ago in England, this has happened. So entirely benign condition, because the patients are suffering, probably they have done. But now there's no place for surgery. If you do surgery, the chronic pain will increase. So management is largely conservative, right? Tamoxifen, I have given few patients, but it works really well if you give tamoxifen. That's the last resort that we have. So that's not the first choice, right? Reassurance, on top of that, NSAID gel, on top of that, oral medication. Last resort is tamoxifen. Okay.
Like Matti said, tamoxifen is never on the first visit. This is after several months. If you have failed everything in a patient who is absolutely miserable because of unbearable pain, you may consider just to improve quality of life, not anything otherwise.
And you can start with 10 milligrams, not 20. As for breast cancer, we can give 10 milligrams.
Right.
What's the pace of aspiration for larger cysts?
So we'll come into that. We'll come for cyst, yes. So the radiologists like to make our life complex again by giving complex reports like this. Sometimes they say simple cyst, sometimes they say complex cyst, and sometimes even they report as complicated cysts. Yes. So what do you think they mean by saying it's a simple cyst or a complex cyst or a complicated cyst?
I'm not exactly sure, but could be the whether it's heterogeneous in nature, that might be.
So simple cyst is ultrasonically having a circumscribed margin with hypoechoic density with a posterior acoustic shadow enhancement without any solid particles. And there are no echogenic debris as well. But when it comes to complicated cyst, it's usually sort of heterogeneous, not very homogeneous as in simple cyst. Plus, there can be echogenic shadows, but not septations. But when it comes to complex cyst, all these things can be there, plus or minus thick wall in the capsule. And these septations can be significant.
Sandipani, over to you to simplify us this to us.
It's a simple cyst. Well circumscribed, a thin wall, and there is acoustic enhancement. This is not hypoechoic, this is anechoic. This cystic component, fluid is anechoic, no echoes. When it comes to complicated cyst, it could be thick wall, internal echogenic debris, or fluid layer. Could be due to secondary infection or hemorrhage into cyst. Those are the things which can happen into the cyst. But when it comes to complex cyst, there could be a solid component within the cyst with the stroke, the vascularity. There could be a posterior enhancement, as well as if the solid component is more hypoechoic component, there could be high acoustic shadowing as well. The microlobulation can occur in the margin. Those are the things in the complex cyst.
So
And the last one is intracystic papillary breast cancer.
Right. So how can what is the clinical relevance of knowing this, and how will our management change depending on their reporting? So the patient comes with the reports. Sorry, is it Jaishni? So there's ultrasound scan saying it's just a simple cyst, 1 by 2 centimeter size, same size complicated cyst, and then there's the same size complex cyst in 3 different patients. Does the management change?
If there is a solid component, we might have to go for a core biopsy of the solid component.
I think that's quite clear, and we'll have to agree that for a complex cyst, if there's a solid component, we will have to go for ultrasound guided.
BIRATS 2 in most situations. One is definitely BIRATS 2. BIRATS 2 is benign, no further interventions. BIRATS, definitely the third one is a BIRATS 3. Middle one, depending on the type of complication they see, they may report it as a 2 or a 3. In most situations, it's a 2 again. So again, the management is nothing. 3 is a probably benign, but there's a solid area or a thick wall. So that has to be biopsied for us to be absolutely sure we are not missing a malignancy.
So we can safely say that patients with simple cysts and complicated cysts can be reassured, and complex cyst needs further investigations. Another question for the panelists may be, if a patient, yes.
Complicated cyst, as mentioned, it could be hemorrhage into the cyst or infection. So patients come with symptoms,
yes,
with tenderness and pain. So we can't just reassure, give some NSAIDs, or if you think they are having infection, simple antibiotics, but not surgery, right?
What is the place for aspiration of a large cyst to relieve mastalgia?
There is no point in aspiration other than if you think the patient anxiety will be relieved by aspiration, now the patient knows, okay, now the lump is disappeared. Other than that, there is no definite reason to do aspiration.
Yeah, it is just purely symptomatic management. So unless it's a very big cyst and very symptomatic, a simple cyst, we would not just aspirate, because more often than not, they recollect. Within a couple of days, patient is back saying, okay, that was disappeared has come back. So we are not really achieving anything much by aspirating simple cysts. So general management is no intervention, reassurance, and maybe symptomatic treatment with medications, NSAIDs, and follow-up if necessary. More often than not, they don't require a definite follow-up, but complex cysts are totally different.
All right, so we'll move on to the next case. So here we have a 50-year-old female presenting again with a nipple discharge. This time it's greenish yellow in color. She has noticed it only on self-breast examination. Otherwise, there has not been any spontaneous discharge. You examine the breast, it is normal, and you can't elicit this discharge as well. It's you, isn't it? So now what is your thought process on this? So there's a greenish yellow discharge that the patient is claiming to have had, but your assessment is normal. It's recent onset.
So according to this patient's history, my working diagnosis would be that she's suffering from duct ectasia. Considering the fact that the breast examination is normal without any associated erythema or tenderness, that leads me to think that this looks like a non-infected duct ectasia, and my management would move on from that.
So what would you do? Would you reassure her, or would you go ahead with a scan, mammogram?
I would reassure her at the moment that I would also like to do an ultrasound, a baseline ultrasound scan as well, in order to confirm the presence of dilated periareolar ducts and the presence of any debris. And if the patient was symptomatic with any tenderness or erythema and any systemic signs like fever, I would want to get the baseline inflammatory markers done as well. After that, I can reassure the patient and
Let's move, just stop there and ask the panelists, what do you think about your imaging in this kind of patient?
Okay, it depends on the context. Most often, I think most of the time what we get are patients who have somehow squeezed their nipple hard enough to get a minute amount of fluid because somebody had told you to do that, told them to do that. When you examine with the greatest difficulty, you can get the patient to express maybe a 1.1 ml of tiny fluid, maybe coming from multiple ducts. In that situation, after a thorough examination, and if the patient doesn't have any risk factors, I wouldn't do anything beyond that. It is not really duct ectasia even. It's a physiological thing. Almost all women around 40-50 years, if you squeeze their nipples hard enough, you will get a tiny minute discharge. So I would advise them that it is nothing to do with the malignancy. I would advise them on self-breast examination, but not to squeeze the nipple to elicit this tiny discharge, and reassure and send them off unless the patient has other risk factors. What I don't agree with is, now in this situation, if at all, what we need to do is to exclude a malignancy. If you think of if you are thinking of sinister pathology, so ultrasound alone is not enough. She's 50 years. So I would, if I'm investigating, I would do a mammogram plus ultrasound. That will tell me whether I'm missing another lesion as well before I reassure the patient if I have any doubt or the patient has risk factors. And then there is nothing to do because it is not infected. Otherwise, there's just reassurance only.
It's a mammogram plus ultrasound scan.
Yeah,
she's at the age where you have been doing screening mammograms as well. So why not do a mammogram when she's symptomatic? Okay, there's no rationale otherwise.
Yeah, so on that basis, I think we have to investigate if you're going to reassure.
Yes.
That there is nothing wrong.
Yeah, and the other thing is this nipple discharge on expression. You have to discourage. It's not part of the self-breast examination. So how much we have given this message to the MOH, still they are doing, right? And unnecessary anxiety is developing in the public, the patients who is going to this well women clinic, coming, running us towards us, asking what to do. Now there's a discharge, whether I have a cancer inside, right? The nipple discharge that we are focused is on spontaneous discharge. Otherwise, it's like pricking your eye in the morning and say, well, see, there's tearing. So it will tear, right? Because the eye is designed to tear if there's any insult to the eye. So likewise, breast is a gland. You give this information, your breast is a gland, it will have secretions. When you try to squeeze something, it will come out, right?
Yes. So we go ahead and do an ultrasound scan. And what, Sandeepani, how would we diagnose duct ectasia?
These are two ultrasound images of dilated duct. Usually we consider if the diameter is more than 2 to 3 millimeter, it is dilated. This is the axial image. This is sagittal image. And we can see we have to assess the intraductal material or solid areas. This is hyperechoic area. The hyperechogenicity is a benign feature. It could be due to insufficient secretions. Then this is the duct in the longitudinal view. This is the diameter, and it's adjacent parenchyma normal. No intraductal vascularity on color Doppler. No calcifications. If there is calcification, we can see it at punctate echogenic areas in it. These are BIRATs too. But if there is suspicious features, intraductal vascularity, solid areas, wall thickening, actually we have to go with BIRATs 3 or 4. This is actually ductogram, but on mammography, we can see tubular structures pointing towards branching and pointing towards nipple. Sometimes we can see calcification even, then we can go ahead with higher BIRATs classification.
Thank you. Just let me switch the slides. So I think it's a straightforward case. It comes as duct ectasia. And we generally don't go for histological diagnosis, but just to briefly touch on that, Charisma.
So if we do go in for histology, this is what we see. We see a dilated benign ducts with foamy histiocytes within the lumen. There is intense or marked inflammation surrounding the ducts, which is both mixed inflammatory cells, basically lymphocytes, plasma cells, and neutrophils. And if it's a later stages, there might be areas of fibrosis, which you can see around it.
Right. And basically the management is reassurance and review SOS. So we'll quickly move on to the next case then if you all don't have any questions.
Patient comes infection, same duct ectasia, we don't have that coming up no later.
We have few mastitis patients coming up. Yes.
Okay. So we can discuss that.
Then is that all right?
Yeah.
Yes. Okay. So this again, it's a very straightforward history. You can see a 40-year-old female presenting with a lump 2 months duration. She recalls a blunt trauma to the breast. You feel a nodularity with mild tenderness. What is your clinical diagnosis based on this? There's no discrete lump, but you can feel some nodularity. So comes with a mildly painful lump in the breast for 2 months, which she has noticed following a blunt trauma to the breast. What could this be? With the trauma history, what is it likely? I mean, it could be anything else, but what it is likely to be? Most likely it could be a sorry?
Fat necrosis.
Fat necrosis, as it says. So do you want your slides? So what if you suspect fat necrosis, how would you confirm your diagnosis?
I will still go ahead with the ultrasound of the breast.
Yes.
And since it is a 40 years female, I would do a mammogram as well.
Right. So we go ahead with the ultrasound scan. And so if it is a 30-year-old, would you do an ultrasound scan only? Yes. Can the ultrasound scan be diagnostic of fat necrosis?
Yes. With the clinical history, if we can do the targeted scan as well because she has area of tenderness. When we go through the ultrasound, this is the tenderness area. There is ill-defined hyperechoic area. with mild parenchymal edema could be there. And sometimes there could be central ill-defined cystic areas due to a liquefaction of the fat, giving rise to this appearance. But we can do the mammogram as well.
Mammogram is not there. Do you want my mammogram?
You showed it earlier.
In my one, is it?
Yes.
Okay. Right. So,
yeah,
so that's
this is the one, the heterogeneous area with coarse calcification. This is the chronic one with lucent lesion in it with the central lucency and the peripheral rim. This is a oil cyst. Typical appearance of the oil cyst due to fat necrosis. The coarse calcification is benign calcification.
So the patient, what would you do if the patient comes with the ultrasound and mammo, and the radiologist has confidently said that it's fat necrosis?
I will reassure the patient and will not proceed with any investigations thereafter.
Well, I generally follow up with a scan.
Classic appearance of malignancy. And sometimes even in malignancies, patients will give a history of trauma, uncommon. So just the presence of trauma doesn't exclude a malignancy. So remember that. But what happens if they have a minor trauma, then only they will start touching the area. Then they will notice that there's a lump. So it doesn't really confirm, no excluded diagnosis of malignancy. Right? So it's remember, if somebody comes with a malignant looking lump, we do imaging. If the imaging is normal in this context, clinical, because we have a suspicion, better to follow them up. I always follow these patients up at least for 3 months or 6
Because ideally, if it's a fat necrosis, it should subside eventually.
disappear completely.
Yes. Charisma, what? Yes, Nalinder.
What I do is I also follow up. On top of that, I give them symptomatic treatment NSAIDs to relieve the edema and settle the inflammation. So if there's anything sinister underlying, so we can easily see with the follow-up scans.
So if we do a biopsy, can we safely say it's a fat necrosis?
Yes, it's quite diagnostic because you will see that the adipose tissue and all will be infiltrated by a dense amount of inflammatory cells, especially foamy histiocytes. And there'll be a lot of multinucleated giant cells. There might be a few neutrophils as well, and these hemosiderin pigments can be seen. So it's quite diagnostic of fat necrosis on histology.
Right. So it's quite a straightforward case. You will go ahead and follow up the patient. So the next case. So this is a 30-year-old female lactating mother of a 2-week-old baby, first baby, presenting with a painful lump in the right breast, and she's febrile as well. Yes.
So I'll investigate this patient with the ultrasound scan.
What is your clinical diagnosis before you?
Mastitis due to
lactational mastitis.
Abscess, no? Yes, mastitis, it's an abscess. You can see she's having fever, so there's an abscess. Yeah.
So what would you do? Proceed.
So I'll do a ultrasound scan to confirm the abscess formation.
On examination, you will feel a fluctuant area. So, clinically, it's an abscess, so there's nothing to really confirm that is there. So what will you do?
So, can manage with the aspiration if it is a large abscess and may need incision and drainage. Incision and drainage.
So this is, I think, one place where we violate the principle of adequate incision, and we bend the rules here for a particular reason. We don't recommend incision and drainage. You have
2 reasons. One thing she mentioned, first is more important, if you do I&D, patient will never be able to breastfeed after that. With a big wound, baby will not be able to feed, mother will not be able to feed. So one situation, management is antibiotics, analgesics. You can do regular, if necessary, regular ultrasound guided aspirations. And advise the mother on regular feeding. That is something mothers are very scared to do. When there's an abscess, they are worried the pus will go into baby's body. Then nothing like that. Feeding is a treatment. It's a form of treatment here, because the reason for the abscess formation is a blocked duct, solidified milk, which has subsequently got infected. So letting the milk go out is one form of treatment. So either mother should feed the baby regularly or they should use a pump and empty the breast as much as possible. So we do ultrasound guided aspirations as and when necessary, antibiotics, plus mother needs to regularly feed. What we advise them is feed always first from that side, the affected side. Keep that breast as empty as possible so that infection will resolve like any other place. If there's a UTI, we ask them to drink water so the things will wash and the infection will settle much faster.
It's same. So if sometimes what happens is because of the pain and when we have put dressings after aspiration, it's difficult to feed the baby. So it's better to express breast milk rather than using a pump because pump are also very painful. So anyway, the idea is to empty the breast.
So clinically, if there is only lactational mastitis, will you still go ahead with an ultrasound scan? No fever. I think, will you go ahead with an ultrasound scan? Why? Is it only to diagnose mastitis or we've just discussed? Is it to, we want to see if there's an underlying abscess formation. So because we need to do ultrasonic guided drainage. Deep, yes.
So we get the scan to find out if there's a drainable collection to confirm the diagnosis, but to see whether there's a collection. And always we request ultrasound plus or minus aspiration. Not a diagnostic ultrasound, but it's for aspiration of the same setting.
Sandeepan, you want to just discuss? Yes.
This is the initial stage. We can see the parenchymal edema, skin thickening, and increased vascularity. Here there is no collection, but here, yes, there is a collection here, but this is a non-infective galactosele. I put this for the differentiation with echogenic material in it. But here with the inflammatory features, there is a collection with homogeneously low echogenic material inside with acoustic enhancement. This is an abscess formation with the increased peripheral vascularity and no central vascularity in the abscess.
So I think we all agree that repeated aspiration is the best if there's an abscess formation. What if there's a galactosele?
So galactosele, it's benign. So if it is not infected, you don't have to do anything. You can, if the patient is getting
Yes.
symptomatic, it's painful, you can advise some painkillers. And if it is really getting enlarged, we can aspirate. Otherwise, there's no surgery for that.
In fact, aspiration can make them infected galactoceles or abscesses. That's a fairly common thing that happens. So unless it is infected, I follow the same approach. I wouldn't aspirate it and just leave it. After a while, it gradually will get absorbed. But if you try to put in a needle, there's a risk of it getting infected. Then we have to deal with an abscess after that.
I think Sanjeev mentioned that, but to highlight it again, what if the mother asks whether it is okay to breastfeed in a patient with the breast that has mastitis plus an abscess? Would you reassure and tell the mother to feed from that? Yes, that's a very common question that they come and ask. Right. So then, sorry, we'll move on to any questions? Yes.
Yeah.
There are two lines compromised over the abscess area, or for example, if the population take to be aspirated, is there a applying case on an IUD?
Okay, if already the skin is necrosed and the pus is coming out, you just press it and take it out. That's a very different scenario. But if the skin is not still intact, unless it is completely necrosed and it's pus pouring out, I would not touch it because of the reasons we discussed. Cosmetically, it is unacceptable. Efficacy-wise, we know aspirations work, and breastfeeding also going to be compromised if we try to do any surgical INDs.
And milk
I
fistula.
can't remember the last time I did one for.
Yes, no, yes. They can successfully be managed with, yes.
And apart from cosmetic, the chronic pain
Pain.
in the breast. Now, initially we discussed about Mastalgia. So these are things that will contribute for a chronic Mastalgia. So if you can
treat without any surgery, why not? So we all over the world, we are not doing any INDs for breast abscesses now. It's repeated aspirations and antibiotics.
Okay, one question. What if the patient starts coming back with repeated abscesses in the same location? Lactating woman, repeated abscesses, same location you have been aspirating, but every couple of weeks she starts coming back with repeated. Resolve, comes back. Resolve, comes back.
Culture of the occupants that are present and offset for hemoclosis feeling as well.
Next person. Or any seniors from the front? But it's all, no, this is a localized area, all inflamed, tissue planes are not clearly seen. So you cannot clearly see whether there are solid areas, etc. So do you have any other possible differential diagnosis in this situation?
Should we look into? Yeah. No, sorry, I was going to answer.
Yes.
No.
We have to think like granulomatous mastitis in this situation.
Okay, that is one.
And underlying duct ectasia or
Unlikely. Any sinister? Anything else? Sinister, he has given the word.
Yes.
Malignancy. Remember, enough and more patients we have seen where abscesses had been drained repeatedly without ever taking a biopsy. So you should never ever forget that fact. If somebody starts coming, not a lactating woman for the first time, but if they start coming back, couple of times, same place, then think of the possibility of a malignancy. So what would you do? A co-biopsy.
So the next question I will run, case I will just run through. A 40-year-old female presenting with a painful subareolar mass. Clinically, you see an localized inflammatory area. The clinical diagnosis is unfortunately given in the picture, suggestive of a periductal mastitis. Have you all ever come across periductal mastitis? I guess if you do, when you go for foreign training, you will encounter a lot because a lot of females have it because they smoke. It is associated with smoking. Pathology-wise, is there anything you want to add, Charisma?
Squamous metaplasia of lactiferous ducts is also called a SMALT. So this is the one which later progresses into duct ectasia as well, right?
Okay. Do you have a, yes, sir. So you'll obviously go ahead and do some imaging, and what will you see, Sandeepani, in imaging?
Yes, the ultrasound usually is subareolar, a dilated duct with central inspissated echogenic material and hypervascularity in the periphery. And on mammogram, we can see that chronic form with the inspissated secretions get calcified, rod shape, branch in calcification pointing towards the nipple.
So just to the panel, how do you manage periductal mastitis? Because I think it's a rare condition.
So it's a benign inflammatory condition. So as Kanchana mentioned, the most identifiable risk factor is smoking. So but because we don't have smoking women in our setup, it's rare. But this is largely overlapping in our setup with granulomatous mastitis. So pathology-wise, there are overlapping areas as well. The problem is you don't get cases in or the granulomas in this periductal mastitis, but the plasma infiltrate, lymphocytes are already there. It's an infective inflammatory lesion, and it's mainly around the ducts, right? So you can manage with antibiotics, analgesics, anti-inflammatory medication. You don't have to do surgery if it settles on its own with these treatments. You don't have to offer any surgical treatment.
Right. So
I think
yes.
the true periductal mastitis that you see at the periareolar margin is quite rare. We see very, very infrequently, but we see probably far more duct ectasia with infection in our context. Somebody comes with a subareolar painful mass with features of, if you do a full blood count, CRP, they elevate, sometimes they do have fever. So it's a duct ectasia with infection. That is quite common, especially in older diabetic women. But true perioral mastitis, this periductal mastitis is very, very rare. We may see one per year, unlike in the West.
So in the same line, we look at another patient who has inflammation of the breast. 35-year-old female is presenting now with recurrent mastitis of the left breast. You can see she has undergone, it's not very clear, is it? You can see an erythematous area. She's a mother of 2 children, currently not lactating. So she stopped lactating, let's say, about 2-3 years ago. So these are some of the pictures of similar presentations of these patients. Recurrent mastitis. What do you think it is? Has the mic has to come now to Andrew, is it? So chronic mastitis, recurrent, not resolving with antibiotics, very bothering to the patient and the surgeon because they are recurring. What could this be?
Could be an inflammatory breast CA, we have to exclude.
It could be any other inflammatory condition apart from breast cancer?
Granulomatous mastitis.
Yes. Granulomatous mastitis.
Inflammatory breast cancer wouldn't be recurrent. If it just
Progressive.
short history, then it will rapidly progress. This is a condition not like that, mostly isolated to one area. You may see a fluid collection and pain, and most of the time, by the time they come to us, they have seen several other doctors and been on multiple courses of antibiotics with limited, very limited or no response. That is the typical presentation that we see. So how will you manage? What is your next step? Somebody has come, let's say 2 months history of recurrent this swelling, pain, etc. And you find erythematous area maybe with underlying collection, non-lactating woman. Yes. Who has the mic? Yeah. What is the management?
And we have to investigate for chronic granulomatous mastitis like tuberculous mastitis.
So how will you do that? Tell us. What steps would you take?
So first, yes, just let's for any lump, what would you start off with? So you have this patient with an inflammatory lesion in the breast. You start with?
I'll start in imaging, like ultrasounds and mammogram.
Okay.
Probably, and
It's 35. Do you want to do mammogram as well?
probably ultrasound is enough.
Then ultrasound shows you see evidence of inflammation with maybe some fluid collections around the area.
Okay, just I let Sandeepani then describe until you collect your thoughts into what to do next.
This younger patient, we do ultrasound. We have to correlate with the history. And we can see tubular or nodular hypoechoic areas surrounding fat necrosis, sometimes hypoechoic shadows, and increased vascularity. If we go ahead with the mammogram on elderly patients, we can only see asymmetric densities in the breast, ill-defined densities. These are the appearance of granulomatous mastitis.
Right. So you have the radiologist gives you, yes? Sorry.
We can give sometimes according to history by RAT 3 or sometimes by RAT 4. 5, yes, 5.
Yeah, sometimes we get 5, yeah, 4. So you have this patient now, you got the scan, the radiologist has suggested granulomatous mastitis. What would you do?
Additionally, I will do investigation like ESR and MANTO.
But how would you confirm your diagnosis? I agree you have to do ESR, but...
And then you have to go for a co-biopsy in patient.
Yes, you need to go for a co-biopsy. Why do you need to go for a co-biopsy? Oh, yes, as you said, we need to exclude
Granulomatous reaction.
other causes, yes, to call it, diagnose it as idiopathic granulomatous mastitis, you need to exclude other common conditions, such as as written here, tuberculosis. Yes.
How do you exclude tuberculosis? Do you routinely exclude tuberculosis in these patients?
So we look for the caseous necrosis part in histology. If it is not there, for our safety, we just send for TB, PCR. But before I start my intra lesions, but I start.
Become positive?
No, only in one patient. Only in one patient.
That is, if you read about this, they describe very high incidence of TB in these patients with granulomatous mastitis, especially in India. Sri Lanka, we have very limited information. I also used to investigate, but
Maybe not now.
yet to come across the
Yes.
patient. So I nowadays really don't do, because so far I have never had a patient who is positive for TB in Sri Lanka, although the literature mentions where the high incidence of TB.
Yeah, same. So we don't do TB.
Okay.
Fungal infection.
Yes.
So,
Um,
I haven't also come up with sleep patient.
I've seen only one patient throughout this career, but for exam purposes, let's say for them, what should be the answer?
Topic that they have come with Pyreth's 5 classification with multifocal lesions.
Yeah.
Then ultimately ended up.
So can I ask a question from Charisma? So when we do the core biopsy, can we suspect TB versus granulomatous mastitis based on the core biopsy?
If we do see cases
Yes,
necrosis
yes,
and
yes.
all, we more or less presume that it is TB. But having said that, not all TB cases present with cases necrosis. Majority of the time, there's no caseous necrosis. You just have epithelioid histiocytes with giant cells around it with the rim of lymphocytes. So we really can't on that in that case.
If by any chance the histology says there's caseous necrosis, I don't start the steroids. If it doesn't, I start empirically before TB.
Also with caseous necrosis, also not necessarily that Zeal-Nielsen will be positive for the acid pass bacilli. So you'll need to do other auxiliary tests.
But so for them, would you say we have to exclude tuberculosis before starting treatment for granulomatous mastitis? All right.
Granulomatous mastitis, anyways, is a diagnosis of exclusion.
Yeah.
So you'll need to exclude every other thing which causes it.
So the management, I think I will let the experts discuss on that rather than giving them. How would you manage granulomatous mastitis? I think it's not really fair to ask them.
Controversial topics on how to manage granulomatous mastitis, because we have very little evidence. So probably we have different ways of managing.
Yes, I think we all three of us have 3 different ways.
So the first line is not surgery. The first line is I treat with steroids. We used to do oral steroids only, but that has now changed. So now I select the patients. If it is patients who are having diabetes, patients who cannot have
Nalinda, can you have the mic a little bit closer?
patients who are diabetic or patients who cannot have oral steroids, I give intra-breast hydrocortisone injections repeated. So once in 2 or 3 weeks, I give 300 to 400 milligrams intra-breast, intralesional and perilesional. Initially, I give some flucloxacillin as well, just to counteract any infection. So what I've seen is after 3 cycles, if you are going to see a good response, you will see it. And sometimes what happens is you will not be able to completely eradicate the lesion, but you will be surely be able to shrunk the lesion. When the lesion shrinks, I offer surgery for that localized area only, do a excision biopsy. Patients who are taking the oral steroids, the prednisolone, the literature says you have to give 60 milligrams. But I don't give that much. I give 30 milligrams daily. You have to continue that for about 6 to 8 weeks. So I tailor the dose, and if there is any good response, as in the intra-breast steroid injection, if the response 100%, you don't have to do anything. You tail off and stop it. But if you are going to have any remaining component, you do the excision of that. And sometimes I have seen patients, when they present with almost 3/4 of the breast is destroyed. Right? There is no way you are going to control that, but I give intra-breast hydrocortisone, control the disease to some extent, and do a wide local with a reconstruction.
So again, I told you we have different ways of managing. So if somebody comes to granulomatous mastitis, like what is it, sometimes 3/4 of the breast is involved. If possible, I give both oral as well as intralesional and perilesional combined together. If it is a large area, sometimes you can't really inject the whole area of the breast. In that situation, I may give high dose oral steroids. I also start off with 30. And in about a month's time, when the lesion has shrunken enough, then I give intralesional and perilesional steroids. So more often than not, with combination of oral plus local, we can manage this patient. Only again, I use a different steroid. I use either triamcinolone or methylprednisolone for local injection, oral prednisolone or methylprednisolone, again those for oral. When the lesion is small enough, like what I said, in most situations, it doesn't disappear and it becomes very controllable with steroids. However, when we stop in some people, it comes back. So we can go back to the same. I have a very high threshold to operate simply because even after we remove a particular area, the disease come back.
A low threshold or a high threshold?
Sorry, very high threshold. Sorry.
A high threshold to operate.
Operate, because even if we remove it, they can get the disease in another area. So therefore, I am very reluctant to offer surgery unless I am planning on a very wide excision with a reconstruction. This is again for a benign condition unless it keeps on coming back several times. So at least I try 3 cycles of steroids. 3 cycles in the sense, first cycle is 3 months generally. So 6 weeks of oral plus monthly 3 injections for 3 months. And most of the time it resolves. It comes back a few months later. Try the same again. Third time with surgery immediately after, once it is shrunken, I offer them surgery. This is my personal way of managing. Not evidence-based, by the way, because there is hardly any evidence. Whatever the available evidence is very limited. But having said that, now Europe, they have started a new registry for granulomatous mastitis because they don't also have much data. It's a disease that is prevalent in Asians, especially South Asians. Now, with the high South Asian population in Europe and England, they are also seeing a much increased number of these patients. So they have started this registry there. Recently, it was discussed at iBreast.
Okay.
So they have started that registry.
So can we safely say that our first line would be antibiotics and steroids? A trial of
I don't know. I
before
actually don't
surgery.
give antibiotics even because I have not seen a response with antibiotics other than to protect them because we are giving steroids.
Yes.
Antibiotics have very little place. And then other drug that has come up is methotrexate.
Methotrexate,
I have
yes.
no personal experience, but a lot of people are recommending methotrexate as an alternative for steroids for granulomatous mastitis. That is another potential drug that we can.
I personally don't have experience on.
Antibiotics, sometimes it erupts and
Yes.
secondary get
Infected, yes. So I also too give antibiotics with steroids.
It is contained within the breast.
And
There's no place.
right. So next one, I'll make it a spot test for you all. Because we are running a little bit out of
It's
time.
a young girl, 18-year-old or 20-year-old with a big bust coming with this lesion in between the breast.
So
That's a typical.
Yeah, so she's had a small surgery as well, you can see, but she's coming again with discharging sinuses and abscesses. So this is a classic case of intermammary
So what is the management? Yes.
sinusoidal sinus disease, yes.
Huh? So she has had 1 excision.
She had
You want to
actually-
go back and do the same again?
The correct history is 2 excisions. So she's had 2 surgeries done.
She has had 2. You are going to be the 3rd one. So what is the natural history of this disease? Can you alter the natural history by excision? Because remember, this young girl, and you are going to leave her with a huge scar right in the middle like a thoracotomy.
I think again it's a very difficult. We see a lot of surgeons do tend to operate.
So the natural history of this disease is it will hardly ever recur after 25 years. By 25% years, majority, it disappears. It dies a natural death. We don't know. We don't know why they get it. We don't know why it disappears. It's called, like what she said, pilonidal sinus of the intermammary region. Typically seen in a young girl who has a big mate with a big bust. So that's a typical patient. and after about 25 years, it disappears. So management is if they get an abscess, early inflammation, antibiotics. If they get an abscess, do a tiny drainage, support that with antibiotics, and let it be. I don't know. I never excise. I used to do, but I know if I do, I'm going to be the
Fall into
person.
trouble, yes.
Nalin,
It's the same. Only thing is, it's difficult to reassure patient because sometimes
Yes.
they are very symptomatic. First discharge, they can't wear anything. They can go to their work, studies, or anywhere. So it's very difficult to reassure such a patient. So you need to do something. So you might able to do antibiotic creams, repeated dressings. So cutting might help, but if you are doing for the first time, you have to do a larger excision, go right down. Right down to the deep, to the almost the periosteum of the sternum, and take the tissues like you are doing a pilonidal sinus in the natal cleft, and proper stitching and scar creams and everything. If you're doing it properly, but repeated once, it's not going to help. So manage constantly as much as possible.
And perhaps even when you're embarking on the first surgery, you'll have to tell the patient that this might recur.
Yes,
Definitely.
that's very important.
Right. Again, a spot. I don't know whether it's clear to you. A patient comes with a painful cord-like thread in her. This is the right breast. I don't know whether you can orient. That's the axillary area. This is the breast. A painful cord-like thread. It's very rare, but you might come across. It's like a subcutaneous cord-like induration that you can see. It's slightly tender to touch. Painful. Okay, so while you're thinking, just switch to this. Sorry, Mondos? Is this Mondos? Yes. So that is called Mondos disease. It's rare. Do you want to, if you do an ultrasound scan, what will we see?
We can see a nechoic tubular lesion with that beaded appearance, no vascularity in it. That peripherally there can be that normal vascularity is there. That is due to thrombophlebitis.
Yes, it's a condition, thrombophlebitis.
Dilated vessel with the internal intraluminal thrombus, chronic thrombus.
So I guess we just manage with NSAIDs and reassure Mondos, thrombophlebitis. So we quickly move on, just doing some small cases, and that I think, okay, the last one under this section, again, important topic. A patient presents with mild pruritic scaling lesion in the right breast. So if a 52-year-old female presents with a pruritic scaling lesion for 2 weeks duration in the right breast, it's just say scaling lesion, regardless of whether it's pruritic or not. Who had, is it you now? Oh, you have it, okay. Yes. What are your concerns?
The Paget disease of breast.
What will you do? What is your management?
So breast examination is normal, only this lesion is there.
Go ahead with ultrasound scan and mammography.
No.
We can go with the skin biopsy and skin biopsy. So full thickness skin biopsy. So this can be associated with underlying DCIS. So that need a complete triple assessment. And if there's no underlying and if there's underlying DCIS, that need excision along with the
the Pagets and the DCIS?
Not clear. Sorry.
So this can be associated with underlying DCIS or there may be not, sir. Yes, sir. Then sir, the Paget's disease need full thickness skin. Yes.
Which part? Full thickness area from the nipple. You can put a slit and close it at the end, and that will confirm the diagnosis. One thing that we should never do is prescribe these patients steroid creams like GPs do. You may do it and go back to the if the areola area is involved more than the nipple, or if it is bilateral, it is more like to be eczema. Whereas in this lesion, you can see it is a nipple that is affected. So anybody coming with primarily the lesion affecting nipple, you always need to suspect Paget's disease. So the treatment, if at all, you can try a steroid cream not more than for a week. By that time, if it is not completely resolved, but having said that, Paget's also sometimes gets better with steroids. Always do a biopsy. You need to have a very, very low threshold for a nipple biopsy in these patients. That will confirm the diagnosis. So, by the way, by the time we get these patients, most of them, they have been on steroid creams prescribed by GPs for a long time. So straight away, all that we need to do is to go for a biopsy. So if you remember anybody coming with a lesion in the nipple, Paget's disease, unless proven otherwise, you will not miss Paget's disease. Otherwise, it will progress. So the management is you examine and exclude underlying lesion, image, then if everything else is clear, do a biopsy from the nipple. If it comes as Paget's disease, but the management.
Shall we just brief the radiology and pathology part? Right, okay. So so we do the mammogram.
Yes, as Prof told, it could be negative
Yes.
sometimes, but ultrasonically there could be thickening of the nipple and the subareolar region with high vascularity and can be associated with axillary lymphadenopathy.
Okay.
And on that mammogram, the spot view, we can reveal more details, the thickening of the skin, the nipple, and if it is associated with the malignancy, there could be retronipple microcalcifications. For further characterization, we can do the MR scans.
Right. So we do a mammogram and a scan. They are normal apart from the thickening. And you do a punch biopsy. Yes, Karisma.
So punch biopsy, normal nipple and areola, you just see a stratified squamous epithelium. This is what a Paget's looks like. It's basically clusters and singly scattered, very atypical cells you will see throughout the full thickness of the epidermis. And when you look at these cells, they have these enlarged, very pale cytoplasm, enlarged nuclei with prominent nucleoli, and you get this dense inflammation in the dermis. Thing is, if there is so it is associated most of the times with an underlying invasive high-grade carcinoma or a DCIS, but we don't have any history like that, then in that case, whether it's a mammary Paget or an extramammary Paget, pathology-wise, there are three differentials which comes into play. So it's either Paget's, sometimes Bowen's or Bobinoid. Bowen's also has these type of funny clustering which occurs. And other thing we need to rule out is a melanoma. So with that, we take all that into consideration if we don't have any history, and we have to do the immunos after that. So this, for the patient, actually, CK7 was strongly and diffusely positive. So that basically points towards Paget's. HER2 also becomes positive in mammary Paget's in about 80 to 90% of the cases. If these were negative, then the other thing we will consider is CK56, which will rule out any squamous Bowen's disease, or we do an HMB45 or a melanate to rule out a melanoma.
Right. So, Pasindu, so the patient question that Prof. Sanjeev asked you, so it's a biopsy-proven Paget's disease. MRI is normal apart from the nipple area thickening. What would you do? What's your management?
So, madam, so then the invasive or DCIS has been excluded. That needs.
Sorry, Pasindu, not clear.
DCIS and invasive carcinoma has been excluded. That needs excision of the.
Excision of only the nipple areola complex, or you are going deeper?
I think, madam, it's excision of the nipple areolar complex.
Well, I would do a central cord. I will go a little deeper to make sure that we don't miss any underlying DCIS or.
Yeah, because like what they mentioned, this is kind of DCIS. It's tumor that is starting inside a duct that is coming up to the nipple and involving the skin. So it always starts from a duct. Duct is inside the breast. So excising the nipple and the areola alone will very likely leave a positive margin. So we need to go a little deeper. That's very arbitrary how far we need to go. Ideally, if you can go right up to the fascia, then you will have a clear deep margin, but we don't go that much because we have to be cosmetic as well. Then in that situation, I would go a little deep and of course always orient the specimen. And then there are different reconstructive approaches. But having said that, mastectomy is also an option if the patient is old, and more often than not, these patients will require radiotherapy. So if the patient wishes to avoid radiotherapy in an old patient, mastectomy is also an option. I'm not saying the first line, but that's another option.
Would you do a sentinel lymph node biopsy?
Mistake.
If only Paget's disease and if you are doing a wide local, no place for sentinel node biopsy. So how far deep we have to go? So if think of Hadfield's procedure you are doing, and go for at least 2 inches, 1.5 to 2 inches deep from the nipple level, so that you can incorporate all the duct, terminal duct system with a wide local.
Right, thank you. So that concludes that section, and we'll just briefly touch on an area that is a little difficult for us to remember, and it's a little confusing for us as surgeons because these are called proliferative lesions. Sometimes we don't know whether we have to manage them conservatively or operate or biopsy. Usually the classic histories, they come with some other symptom like mastalgia. We do a scan and memo, and then the radiologist gives us a diagnosis of a 3 or 4 lesion. And then we go ahead and do an ultrasound guided biopsy. What if this, I think we'll, rather than directing it to you, I'll come back to you all. I'll direct it to the panel. What does it mean when he says atypical ductal hype is purely, it's a pathological diagnosis? Do we have a picture? Yes.
Atypical ductal hyperplasia and low-grade DCIS, the only difference is in terms of the size and the involvement. So if it's less than or equal to 2 millimeter, we call it ADH. If there is less than 2 lobular spaces which are involved, ADH. If it's only one space, but only a portion of it is involved, like is in this case, we call it an ADH. So biopsy-wise, true cut biopsy and core biopsy, a bit difficult for us to differentiate whether it is going to be an ADH or DCIS, primarily because of the fact that we are not seeing the whole picture.
Vitranga, so what is the importance of knowing whether these proliferative lesions have atypia?
If the patient is having atypia, there's high chance of them getting converted to malignancy with time. So
Yes, so there is a slight risk of malignant potential in them, but it is not as high as DCIS. How would we manage if we get a biopsy with ADH? I think guidelines say to manage conservatively and observe because the risk is very low. Do you all agree with that?
If it comes as pure ADH only without any evidence of DCIS, ADH means one step before DCIS, I would just keep the patient under observation and manage. Guidelines are not very clear. Most recommend observation only.
Yeah, same. So even low-grade DCIS can be trying to conservative.
Yeah, so ADH is always manage concept, but keep an active surveillance, close follow-up with short intervals.
Is it okay, Sandeep, if I move on to the next one? So then another interesting topic, which is a little confusing, is lobular neoplasia. Again, we have, Charisma, do you want to just brief us on these types briefly?
So ALH and LCIS is also in terms of the involvement. So if it's less than 50% of your terminal ductal lobular unit which is involved, we call it an ALH. And if it's more than 50%, as seen in the second picture, so basically it's the same thing. You just see distension of the lobules with these very monomorphic looking cells, so if it's more than 50% of the involvement, we call it an LCIS. The classic LCIS is the type of cytology you are seeing in terms of the cells, where it's very monomorphic, it's round, small nuclei. Sometimes you may have a distinct nucleoli, but it's not monomorphic. When the This is still a classic DCIS where it more or less looks uniform. But when it goes on to pleomorphic LCIS, you can see the difference in terms of the cytology, where you can see even in this power, you can see these large, bizarre-looking cells in between. Most of them even be quite plasmacytoid with eccentric nuclei. You'll see more mitosis. There may be necrosis and all. And in this condition, we call it a pleomorphic LCIS. So that's what I'm saying, central comedonecrosis. I think there was a terminology they used in terms of florid LCIS. It's not something that we normally use, but it's basically not, it's a classic variant. It's a classic variant of LCIS. It's just in terms of how extensive it is. So there's a marked ductal extension also, which is involved. That's when we call it a florid LCIS.
So let's see the clinical relevance of this. So Andrew, what do you think? Do you think LCIS behaves as DCIS? If you get a, shall I give the exam badge? Yes, I'll give the exam badge. If you get a biopsy.
LCI is no longer considered as a breast. It's not coming under the.
It depends. Let's say somebody comes with a lump. Somebody comes with a palpable lump, imaging, let's say BIRATS 4B. You do a core biopsy, it comes as LCIS.
In that case, we can go for MRI, the breast.
There's a lesion.
Yeah. So if it is purely LCIS, we can manage conservatively with surveillance. But if there is a LCIS with other component, we have to go ahead with the wide local excision.
Agree or not?
If there is a palpable lump with LCIS, I would repeat the core biopsy and see whether
Same, LCIS.
Still, there I will go with a wide local.
Why? Now he said LCIS is not considered malignant, etc. Now, so why do you want to do a wide local excision?
Because there's a palpable lump, there is can be associated malignancy with the LCIS.
So that is how it goes. If somebody is diagnosed as incidental LCIS, that is what it says, not a symptomatic LCIS, incidental LCIS, it's just a risk factor only. Whereas somebody comes with a palpable lump and you have a suspicion that it's malignant, biopsy comes as LCIS, idealization requires MRI beforehand to exclude multifocality, same breast and the opposite breast, then treat like a malignancy, wide local with a sentinel node biopsy, provided you have excluded other lesion. More often than not, this is a invasive lobular carcinoma. But if somebody comes, you removed a fibroadenoma or something else, and the biopsy comes as a focus of LCIS, that's a different situation. So the context again is important.
So is pleomorphic LCIS, sorry, is it more aggressive? Sorry, Karsu, you can ask. Yes, you can ask.
There's a difference in the management if you get a classic LCIS versus pleomorphic.
Yes.
Yeah. So what we are discussing is classic LCIS. So classic LCIS is a risk factor. So you need to offer either frequent surveillance, chemo prevention, or bilateral prophylactic risk reducing mastectomy. So those are the three options for LCIS. But if somebody comes with pleomorphic LCIS, management is totally different. These patients, the risk of malignancy is very high. So therefore, those patients need to be offered surgery upfront, immediately, like for any other malignancy.
Yes, so for pleomorphic LCIS, you treat as
Pleomorphic LCIS and florid LCIS. Florid more often make masses, pleomorphic large cells. So the guidelines also says to consider them as DCIS, like intermediate and high-grade DCIS, and offer treatment likewise. So we will go for wide local excision if it is pleomorphic or florid LCIS. But the classic LCIS, it's a benign entity, although there's a risk factor.
Right. So we'll just move on to one last case before we wind up. So another not uncommon, but something that you notice is that you come across these radial scars and CLS, so CSL. So Sandipani, how do you diagnose a radial scar?
Yes. Radial scar, it's not common, but in the clinical setup, we have to, there are differentials for this, for malignancy and the surgical scar. What is the difference between the normal, malignant, this is a speculated lesion with the central lucency. This is the lucent area due to presence of fat and thin lone specules. And on ultrasound, we can see the small hypoechoic lesion with the speculation at the margin. The difference of the speculation is in the radial scar, it is thin and lone speculation than malignancy. Then these are the radiological appearance. We can follow it up and we have to correlate with the history, whether there is a surgery or not.
Right. So Andrew, so if you get a patient with the report says radial scar, what will you do? Suggestive of this. Yes, yes.
So the radiological, it's a radial scar. What is the next step?
Is it a risk factor to develop malignancy? So we, under proliferative lesions, we categorize them as conditions, diseases that have a high risk for giving rise to malignancy. Do you think this is under that? So while you're thinking, I'll ask the pathologist to describe us a little bit about what is radial scars and what is complex sclerosing lesions.
So radial scars and complex sclerosing lesion is again in the difference of size. So less than 1 centimeter, we consider it to be radial scars. More than 1 centimeter is a complex sclerosing lesion. So like what you see on radiology, you see a very stellate, very irregular looking.
Yes, it's very malignant.
It looks malignancy. But over the years, what I've realized is when you keep on touching that, there's a difference between when it is fibrosis compared to malignancy, no matter how it looks. So you can kind of figure out whether it is malignant or not. So on histology, when you see, so that central scarring that you're seeing is basically sclerosis with these blue tinge. So this is what we call as elastosis. And you see this ducts and glandular proliferation happening, radiating outwards onto separated by the fibrous bands.
So just to ask the panelists then, what would you do if you see a patient? The biopsy says complex sclerosing lesion.
If you see a radial scar on imaging, excision is the recommendation or regular follow-up. Generally, they do not recommend biopsy of radial scars because you cannot sample them adequately. First option should be a surgical excision. Then only the pathologist will be able to conclusively say whether there is association malignancy or not. Otherwise, you can do a very close follow-up to see if it is a difficult location, etc. Then you can do a close follow-up to find out whether this is becoming malignant, because radial scar is a risk factor for malignancy. Anyway, so those are the two general recommended approaches. Biopsy is not usually recommended.
I usually do excision, so because it looks very malignant on imaging as well. So I don't offer surveillance. If the patient is happy, I will go for excision biopsy.
That's the first line. Excision, no biopsy, just excision is the first line management.
Right, so that concludes our discussion on benign breast disease. If you do have any questions, we can take about other.
Any related or unrelated questions?
Even malignant breast disease questions can be entertained by these panelists.
Yes. Ideally, yes. The reason is, especially if the lesion is small, there's a high chance of you missing the lesion. When you do it radiologically guided, you can see the needle going through the lesion, because our next step will be based on the biopsy. So if the biopsy says negative, are we going to just leave it or do an excision biopsy? So that is a problem. So generally what we do is we always prefer, because risk of a negative biopsy will be significantly lower if you do regular image guided biopsies. So that should be the stand. Even if you feel the yeah, because you will feel the surrounding induration. Because of the desmoplasia or surrounding fibrotic reaction, you will feel always a lump much bigger. But actually the lump is much smaller right in the middle. So with a freehand core biopsy, there's a very high chance of you missing the lesion.
Other thing is, even if the lump is actually large, when you try to do a clinical core, the problem is the center of the lesion may be necrotic, especially in high-grade tumors. Patients with having triple negative cancers, the area of necrosis is much. So you will be hitting and taking the biopsies from the necrotic material, and the pathologist will be at a difficult situation to report. So you might have to repeat it. So it's always better. We always now discourage clinical course and always encourage guided course. Yes, please.
Cytology also, I know the older surgeons love sending it to the pathologist, but I would say it's a very archaic system and prefer an ultrasound guided cytology.
Right then. So let me first thank the panelists.
Any other questions?
So let me thank our panelists for coming today despite their busy schedules. Professor Sanjeeva Senaviratne, Dr. Nalinda Munasinghe, and Dr. Sandeepani Jayasuri and Dr. Karisma Fernando, both of them especially because they've come out of the way for a surgical session. Thank you very much for your expertise and knowledge. I'm sure it helped you all a lot. And I want to thank all of you for joining this session as well. Thank you very much.